Everybody ready? The subcommittee will come to order. The chair will recognize himself for 5 minutes for an opening statement. Today marks our subcommittee's first hearing of 2024. Everybody, welcome back and Happy New Year to you. The Health Committee subcommittee is tasked with one of the most important jobs in Congress, overseeing nearly 1/5 of the United States economy. It's a huge task and demands serious bipartisan solutions to some of the most pressing challenges that have a large impact and are deeply personal for patients and families. That is why today we're continuing the bipartisan work we did in 2023 to bring down the high costs of health care. In 2023, we held numerous hearings focused on health care costs. We heard from witnesses representing almost every corner of the health sector, including patient advocates, hospitals, administration, witnesses, benefits administrators, life science executives, and academics. Our work culminated in the Lower Cost, More Transparency Act, which passed the House in December with more than 300 bipartisan votes. This legislation includes policies that will bring much-needed transparency to our health care system and finally put patients in the driver's seat of their own health care decisions. The legislation will empower patients, providers, and payers by advancing price transparency throughout the biggest components of the healthcare sector. If enacted, this legislation would codify and strengthen price transparency rules for hospitals and insurance companies. Further, it would expand price transparency for clinical labs, imaging services, and ambulatory surgical centers. The 2022 healthcare expenditure data from HHS gives us another important opportunity to identify drivers of high costs and continue looking for additional solutions. In 2022, healthcare spending reached $4.5 trillion and is expected to grow faster than GDP over the next decade. This runaway growth is why we are here. Each year, Americans, businesses, and state governments are dedicating greater shares of their budgets on healthcare. When we look under the hood, we can see how healthcare spending is allocated. Hospitals represented over 30% of the total spend. Physician services representing roughly 20% of total spending, and retail prescription drugs representing less than 10% of total healthcare spending. To put a finer point on this, in the private marketplace, the average growth premium is expected to reach 5% per enrollee between 2024 and 2034. This comes after Medicaid spending grew by 31% between 2019 and 2022. That means those with employer-sponsored coverage will be left paying more of their health care as a result, or seeing less in take-home pay for choosing more comprehensive health care coverage. Or in the case of Medicaid spending, it means state legislators will be forced to make tough decisions between cutting certain health care services for vulnerable patients or other core functions like educational services. This should tell policymakers that it's time to take a different approach than what we have employed over the past several decades. Much of the debate about subsidies to health insurance companies, much of the debate is about subsidies to health insurance companies, and I think the verdict is in. Well-intentioned policies to expand access to coverage are missing a key piece of the puzzle. Right now in the United States, the median household income is $74,580. The average deductible for a benchmark ACA plan in 2024 is $5,241. This means a hardworking individual on average will have to spend 7.5% of their annual income on health care before the coverage provides meaningful financial protection. This is why we have to get costs down across the board. To be clear, I'm not pointing blame at any specific part of our system. We need to work across the aisle and with industry stakeholders to better understand the relationship between federal policies and the cost of care. I look forward to continuing discussing these issues today and over the course of the next several months. I will yield back and recognize my friend, the good ranking member from California, Ms. Eshoo, for 5 minutes for opening statement.
Thank you, Mr. Chairman, and good morning, colleagues, and welcome to the first Health Subcommittee hearing of 2024. As the chairman said, today we're going to be discussing a pressing issue for all Americans, healthcare spending. In 2022, the United States, as the chairman said, spent $4.5 trillion on healthcare. This accounts for nearly 20% of our nation's economy, and per capita, that's almost $14,000 per person. But patients are not seeing better health outcomes. Americans live shorter lives than residents of other developed nations, such as Germany, the United Kingdom, Austria, despite spending double on health care. Americans are also in an affordability crisis. Half of Americans say it's difficult to afford the cost of health care, and 2/3 of Americans say that our health care system doesn't meet their needs. Patients fear they can't afford to pay their bills if they get sick, even if they have health insurance. Yet there is a bright spot that bears our attention today. Medicare, one of our nation's most important federal health care programs, covers more than 65 million people and accounts for 10% of our nation's budget. After decades of rapid increases, Medicare spending is defying trends seen in other parts of our healthcare system. Spending on Medicare patients has slowed to the slowest rate since 2005. Between 2013 and 2019, spending increased just over 2% and is expected to remain relatively flat through 2031. Importantly, costs will continue to decrease as Medicare, for the first time ever, negotiates prescription drug prices. Another policy that will lower healthcare spending is the Lower Cost, More Transparency Act, which passed the House with overwhelming bipartisan support. The legislation will empower patients to make informed decisions about their care by shining a light on parts of the healthcare industry that have remained hidden for too long, such as the profits middlemen called pharmacy benefit managers extract at the expense of patients. I hope the Senate passes this bill quickly. Now, Senate and quickly is an oxymoron, but we can still hope. Congress's job won't be done when the Lower Cost, More Transparency Act is signed into law. There's more Congress can do to lower costs, and we can start by building on the successes of the Inflation Reduction Act, which has lowered healthcare costs for seniors on insulin, prescription drugs, and vaccines. Premium tax credits from the IRA also fueled record-breaking enrollment in health coverage under the Affordable Care Act this year. 21.3 million people enrolled in marketplace coverage during the open enrollment period, including 5 million new enrollees nationwide. 80% of enrollees found a plan for less than $10 a month. Congress should make the premium tax credits permanent to protect and expand health care coverage for all Americans. So together with all of my colleagues here, I look forward to the testimony that the witnesses are going to offer today, telling us what they think Congress should do to lower costs while improving the health of our nation. Thank you, Mr. Chairman, and I yield back.
Thank you. The gentlelady yields back, and I now recognize the chair of the full committee, Chair Rogers, for 5 minutes for her opening statement.
Thank you all for being here today. We have talked a lot in this committee about addressing the impact high health care costs have on patients, employers, and taxpayers, and the work that we need to do to create a less complicated system. More than 60% of Americans are living paycheck to paycheck. It means that they're just one medical bill away from a financial emergency, one doctor visit away from not being able to pay their rent or put food on their table. Let's take, for example, a new mom who has what is considered a good health care plan. All her plan's documents say maternity care is covered. After a few weeks at home enjoying life with her new healthy baby, she gets a bill from the hospital for over $18,000. Next, she receives an explanation of benefits from her insurer. A number of items were denied, but it's not clear why. It claims she may still owe over $6,000. A month or so later, another hospital bill finally shows up for $1,800. So for one childbirth, that's 3 different documents with different amounts for this family to pay. This is just one example of how the current confusing and opaque system plays out for every day in millions of lives for Americans. Something needs to change. Improving price transparency in our healthcare system is a critically important step to begin to address these problems and drive down costs. We ended last year with a very important moment. Our Lower Cost, More Transparency Act passed out of the House by an overwhelming bipartisan vote. But our work is not done. We need to get this legislation onto the President's desk to improve price transparency for patients and employers as soon as possible. Today, we're hearing from experts on why addressing healthcare cost is so important and what more Congress should do once the Lower Cost, More Transparency Act is signed into law. We will hear about how much we are spending on healthcare. In 2022, Spending on healthcare in the United States reached nearly $4.5 trillion. That averages out to about $13,500 per person. Take a family of 4. That means on average it will cost more than $55,000 a year to provide healthcare for that family. Now, of course, not every person or family is average. Some will require more spending, some less. But we all pay the high cost of healthcare through ever-increasing insurance premiums, through our tax dollars, and we know that when employers have to spend more on healthcare, they spend less on wages. One study found that the growth in healthcare premiums over 3 decades resulted in $125,000 in lost wages per family. In other words, when we lower healthcare costs without sacrificing access and quality of care, we are helping increase the paychecks of hardworking Americans. Spending on healthcare is projected to continue to grow faster than the economy over the next decade. This trend is not sustainable, and we have to find a way to reverse it. I believe a foundational first step that is necessary to lowering healthcare costs is improving price transparency. But our work does not stop there. There are plenty of other examples of things driving up costs for patients and employers. One such example is vision insurance, an area that has seen significant consolidation and vertical integration over the past decade. And this has led to the same companies controlling the production of frames and lenses, owning and operating nearly all the laboratories, employing the doctors, and owning independent practices. The result is less transparency and higher costs for treatment. And that's why Chairman Guthrie and I are requesting that the Government Accountability Office examine this issue and help inform the committee on how we can bring more transparency and lower costs for Americans. There are many examples like this one, which is why we're holding today's hearing, to examine how much we are spending on different parts of the healthcare system and to discuss potential solutions to lower cost and put money back into the pockets of hardworking Americans. I look forward to hearing from all. Thank you, witnesses, for being here, and to my colleagues, I look forward to hearing your ideas too. I yield back.
Thank you. The gentlelady yields back, and the chair will now recognize the ranking member of the full committee, the gentleman from New Jersey, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today's hearing builds on the committee's critical work to lower healthcare costs and make coverage more affordable for American families. And there's some good news in this regard. More Americans have health coverage today than ever before, thanks to the Affordable Care Act and the expansion subsidies included in the Inflation Reduction Act. Last week, the Biden administration announced that a record-breaking 21.3 million Americans signed up for health care coverage for this year through the ACA marketplaces, and that's 5 million more people than signed up last year, which was also a record. Millions of families have seen the cost of their monthly insurance premiums go down. In fact, 4 in 5 consumers were able to find health care coverage for $10 or less per month, thanks to enhanced subsidies that Democrats passed as part of the American Rescue Plan and then extended through the Inflation Reduction Act. And this is a big deal, and it's what's possible when you strengthen a program rather than spend years trying to eliminate it. And I am proud of this historic achievement and hope we will act expeditiously to ensure that these subsidies are renewed next year when they're set to expire. But despite all this good news on the ACA front, high health care costs and affordability continue to be a challenge for consumers. This is creating a significant financial burden and preventing some families from getting necessary medical care. More than 40% of American adults say they have either delayed or foregone medical care because of the high costs, and half of adults have reportedly difficulty affording health insurance or health care. So our healthcare system is complex and challenging, and too many patients struggle to navigate and understand the cost of a healthcare procedure or a prescription drug. Patients are not able to easily obtain price information in advance, and sometimes the information is inaccurate and misleading, making it difficult to determine the true value of a given service. Similarly, employers have difficulty accessing data that could help them negotiate lower prices and design high-value plans. Patients also face wide price variations, and the lack of transparency makes it difficult to compare across providers in advance of receiving care. Prices for healthcare services vary widely across different geographic areas, but also across providers in the same geographic area. According to an analysis by the New York Times, a single hospital can have a threefold difference in the price of the same service. Prices of healthcare services also vary substantially in the employer-sponsored insurance market. According to another analysis, the average price of an MRI in large employer plans range from $251 to more than $1,400 across different geographical regions. And patients and employers deserve greater transparency in the prices they pay for healthcare. And that's why our committee, led by Chair Rogers and myself, worked on a bipartisan basis to pass H.R. 5378, our Lower Cost, More Transparency Act, out of the committee, and obviously in the House. Our bill will deliver lower health care costs for the American people and bring much-needed transparency to our nation's complex health care system. And I'm fighting to get H.R. 5378 passed into law, as Chair Rogers is in the Senate, and we look forward to hearing from our witnesses on how we can further increase transparency and lower costs. Now, one area where we need to focus is on Medicare Advantage. Medicare spending is expected to double over the next 10 years, with payments to Medicare Advantage plans totaling $7 trillion. While the Medicare Advantage program offers seniors flexibility in the way that they receive their medical care, it's important that we ensure Medicare remains financially viable and that seniors are receiving the high-quality care they deserve. The Medicare Payment Advisory Commission has consistently found that providing care under Medicare Advantage has cost more than under traditional Medicare. Overpayments to Medicare Advantage insurance companies were projected to be $27 billion in 2023 alone. Despite the large costs associated with the Medicare Advantage program, there is limited data to conduct oversight and ensure that the program is providing good value for our federal dollars. In particular, there's been no meaningful accounting about whether or not seniors are actually using supplemental benefits and if their usage correlates to the additional money insurance companies are being paid. And as Medicare payments for supplemental benefits continue to increase, we have to better understand if they're helping seniors and whether they're being delivered at a reasonable cost. H.R. 5380, led by Representative Sarbanes, would require insurance companies to report data on supplemental benefits, and the legislation passed this committee with unanimous bipartisan support, and I look forward to seeing it pass the House and signed into law. So, Mr. Chairman, today's hearing is an important step in our continued effort to make health care more affordable, and I look forward to hearing from our witnesses. And with that, Mr. Chairman, I yield back.
Thank you. The gentleman yields back, and that concludes opening statements from the members. And when I have opening statements from our witness, I'll introduce each of you and then call on you for your 5-minute opening statement. I think most of you have testified before. If you haven't, you'll have 5 minutes. There'll be 4 minutes in. You'll see a green light. 4 minutes in, you'll see a yellow light. That means you're approaching your end, and so start summing up. When you get to the red light, you've exhausted your 5 minutes. So we'll look forward to hearing from you all. Let me first introduce. We have Ms. Katie Martin. She's President and CEO of Healthcare Cost Institute. We have Dr. Benedic Ippolito.
Close enough.
Say it. Would you say it so we can say it correctly?
Ippolito.
I'm sorry, Ippolito. Senior Fellow, American Enterprise Institute. Mr. Kevin Lyons, the Plan Administrator for the New Jersey State Policemen Benevolent Association, Incorporated. Ms. Sophia Tripoli, Senior Director of Health Policy for Families USA, and Dr. Chapin White, Director of Health Analysis of the Congressional Budget Office. So I thank you all for being here, and we'll call on, first we'll have Ms. Martin. You're recognized for 5 minutes for your opening statement.
Thank you. Good morning, everyone. Chair Guthrie, Chair Rogers, Ranking Member Eshoo, and Ranking Member Pallone, and members of the Health Subcommittee, it's an honor to join you today to share my understanding of healthcare spending in the United States. I'm Katie Martin, and I am the President and CEO of the Healthcare Cost Institute. HCCI is an independent, nonpartisan, nonprofit organization founded in 2011 to foster greater understanding of healthcare spending trends and the drivers of healthcare cost growth among people with employer-sponsored insurance. HCCI houses a unique multi-payer data set that allows us to conduct original research, license data to leading academic and policy researchers, and to produce consumer-facing price transparency tools. High and rising healthcare spending challenges the budgets of governments, businesses, and families, and forces each of them to make difficult trade-offs. Using the most recent HCCI data, we find that total spending per person enrolled in employer-sponsored health plans was $6,467 in 2021. That amount captures payments by payers for healthcare goods and services and out-of-pocket costs paid by enrollees. It does not include insurance premiums or insurers' administrative costs. $6,467 is 21% higher than just 5 years earlier, an increase equal to $1,133. Prices accounted for more than half of the spending increase, $915 of the $1,133. Meanwhile, inflation accounted for $108, and the quantity of services used accounted for $364 of that increase. Since 2019, the change in the mix of services has slightly offset spending increases. While prices are driving spending increases in the employer-sponsored insurance population, there is wide variation in what the price of a healthcare service is. There is no single price for a given healthcare service. Prices vary from community to community across the country. Within the same geographic area, prices vary across providers. Within the same providers, prices vary across patients. Two people can go to the same hospital for the same service and face two different prices, sometimes substantially so. Moreover, prices paid in employer-sponsored insurance are routinely higher, multiples higher, than rates reimbursed by Medicare. Recent HCCI analysis of outpatient services found that employer-sponsored insurance reimbursed rates 3 times higher than Medicare payments on average. Prices for services provided in the outpatient setting are also frequently higher than those same services provided in a physician's office. For example, we found that the price of a basic metabolic lab test performed in a hospital outpatient department was 5 times higher, the same exact test provided in a physician's office or independent lab. Nearly half of people in the United States get health insurance through an employer, and our data suggests that spending for this population continues to grow and is contributing to unsustainable increases in health spending overall. Public and private decision makers need information and data to identify and implement changes that can alter the trajectory of healthcare spending. The lack of comprehensive and definitive information on how the U.S. healthcare system is performing poses an obstacle to understanding what is driving healthcare costs and makes it difficult to develop effective solutions. Transparency alone likely is not sufficient to lower healthcare spending, but more complete data, including data on healthcare prices, can be used to understand cost drivers and design and implement strategies to lower spending growth, improve value, and increase affordability. HCCI's work is just one example of how bringing data to bear on important policy questions can contribute to meaningful policy decisions that respect and reward innovation in healthcare within the parameters of a sustainable healthcare system. Thank you for your time today and the opportunity to discuss these critical issues.
Thank you for your testimony. I appreciate it. And Dr. Ippolito, you're recognized for 5 minutes for opening statement.
Thanks very much, Chairman Guthrie, Ranking Member Eshoo, members of the subcommittee. My name is Benedic Ippolito. I'm an economist at the American Enterprise Institute. I think it's fair to say that the high cost of healthcare represents, I have here, a persistent challenge for policymakers, which may be a little bit generous. I thought that was put into context really nicely in a recent report from Paragon Health, where they showed that just federal spending on Medicare, Medicaid, and ACA subsidies was going to exceed the discretionary budget. Yeah, sure. There was a recent report that showed that federal spending on Medicare, Medicaid, and ACA subsidies was going to exceed the entire discretionary budget in 2024, which is remarkable given how much attention we spend to the discretionary budget. And that's not all of healthcare spending, of course. And so again, regardless of one's priorities, I think that crowds out other valuable resources or other uses for those resources, whether in healthcare or outside. Meanwhile, on the consumer side, a family plan in an employer-sponsored market is now approaching $24,000 a year in total premiums. We heard earlier the median household income is around $75,000 a year. It's very easy to understand then how that starts to eat away at wage growth and affect employment, and that's something that research has borne out. So I think there's broad benefits to lowering healthcare costs, but that does not justify indiscriminate cuts. Instead, the goal should be to target cases where we think healthcare spending is divorced from value. I think there's many such options, but I'm going to focus on one that was included in the Lower Cost, More Transparency Act. In typical markets, you can essentially think of the most efficient producer essentially dictating the price. If there's a coffee shop that opens up next to Starbucks and they can produce the same cup of coffee for half of the price of Starbucks, Starbucks either needs to find some efficiencies, lower their costs, lower their prices, or change their business model, or everyone's going next door. Healthcare ought to have those same market forces. If providers are able to offer the same quality service for a lower price, purchasers ought to shift towards those settings. But current Medicare policy interrupts that dynamic by paying hospitals and to a lesser extent ambulatory surgery centers more than they would pay a physician's office, even if it's a service that we think could be provided in any of those settings. That policy directly increases costs to Medicare's and to beneficiaries, but perhaps more importantly, it has effects outside of the Medicare program by giving hospitals an obvious incentive to acquire physicians' offices. It's a good example, I think, of where spending and value are very tenuously related. So in cases where care can be delivered safely outside of a hospital, paying a site-neutral rate based on the physician fee schedule embraces behavior we would typically see in markets. And I do think that is something that is often lost in this discussion. This is sort of normal market behavior. It has to be done in a relatively prescriptive way because Medicare sets rates, but this is what we would expect in a normal market. So the Lower Cost, More Transparency Act proposes to do this for one subset of services, namely drug administration off campus. I think one can argue for a much more expansive policy, but I will say this is a subset of services for which the arguments for site-neutral payments are particularly compelling. Very briefly, some have argued against this kind of policy because it would threaten the finances of some hospitals, namely, typically you think about rural or safety net hospitals. Ensuring access and hospital financial viability, are reasonable goals. However, it is not a compelling argument for maintaining the status quo, right? Even if the current policy, I would argue, is pretty modest, but even if it does threaten the finances of some hospitals, that does not justify paying all hospitals more in order to accomplish this goal. Instead, a much better approach is to embrace site-neutral payments as the standard, and then either try to mitigate revenue losses for certain hospitals you care about, maybe phase the policy in, or just limit losses at certain types of hospitals. Or I think even better, just embrace site-neutral payments and decide how much you want to subsidize certain kinds of hospitals that are more financially distressed. I think that lays trade-offs more bare, and frankly, it gives you more bang for your buck because you're not spreading all this money across every hospital, including those that are in very strong financial positions. You're targeting it to the places where you really think that they need help. So I'll conclude by saying that's just one of many ways to chip away at high healthcare costs. Other options that increase competition and transparency tend to work in the same direction. And so I thank you for having me, and I look forward to your questions.
Thank you for your testimony. It's much appreciated. Mr. Lyons, you're now recognized for 5 minutes for your opening statement.
Thank you, Chairman. Honorable Chairman Guthrie, Vice Chairman Buxton, Ranking Member Eshoo, Committee Chairwoman Rogers, and Ranking Member and fellow New Jerseyan, Honorable Mr. Frank Pallone, and other committee members. My name is Kevin Lyons, and today I stand before you as a retired law enforcement officer, a member of a school board, a labor representative responsible for the New Jersey's largest public sector health benefits program, and most importantly, as a husband, father, and grandfather. Throughout my career in law enforcement, first as a cop and then a detective, and now as Director of Member Benefits for the New Jersey State Policemen's Benevolent Association, representing over 30,000 active law enforcement officers in New Jersey, I've come to understand that transparency isn't just a policy, it's the bedrock of trust and integrity. We all know when it's missing, the community suffers. It should be no different in healthcare. In fact, the stakes may be higher because when people begin to distrust this system, lives are at stake. But sadly, it's one of the least transparent, most shrouded aspects of our society, despite the fact it compromises 1/5 of our economy. In our policing, we've embraced body cameras and rigorous public scrutiny, understanding that transparency is essential to gain and build the public trust. Yet the opposite is true with many hospitals. Carriers, third-party administrators, and PBMs. We are forced to belong to networks where we are prevented from knowing the price. We are prescribed drugs from a formulary that's largely driven by money and rebates, not clinical efficacy, and we incur tens of billions in foregone revenue from nonprofit hospitals with basically zero oversight or benefit to show for it. This dynamic not only makes it challenging to manage public budgets, as I know all too well, but it also effectively erodes the trust of the people it's supposed to serve. And before I go on, let me be clear. My critique here is not, and in no way, a reflection on the tireless efforts of our doctors, nurses, and support staffs of hospitals. In fact, these dedicated professionals are often themselves victims of the system's lack of transparency. As a labor representative overseeing the second largest public sector health plan in the nation, I've not only witnessed the direct impact of these costs on individual families, I've also witnessed some of the egregious behavior that has led to this crisis. I regularly see instances where our members' hospital claims are paid in amounts far in excess of the billed amounts. And when questioned, my colleagues and I were dismissed, silenced, told this is how carriers price claims, and it was proprietary and confidential. The detective in me isn't buying it. Or consider my colleague, then director of the program, told the carrier to make it easier for members to submit out-of-network mental health claims, to which the carrier responded, quote, "If you do that, you realize they're going to use the benefit more, right?" Unquote. It's nothing short of unconscionable. The financial impact of this broken system that operates in the shadows cannot be understated. For example, in my role on the Southern Regional Board of Education in New Jersey, I've seen healthcare costs balloon from 16% to 18% of our budget in just 2 cycles. These aren't just statistics, these represent unfunded school programs, higher teacher-to-student ratios, and struggling infrastructure. What is more distressing is the fact that I could probably tell you every detail of every line item in the budget, from art supplies to transportation, but what is behind healthcare cost increases? We fly blind and are expected to accept it. To protect what? The business interests of carriers, and hospitals, and PBMs? The financial impact on my individual members, those that put their lives on the line every day, they head to work and their families, is real, and it's a tragedy. Many of our members see a significant portion of their hard-earned salaries, sometimes as much as 15%, consumed by healthcare premiums. And this is before they have accessed 1 ounce of care. The proliferation and peddling of high-deductible health plans mean that many of these families don't see the full benefit of their health care plans until they've emptied their savings accounts. This brings me to the heart of the matter, accountability and the urgent need for action. In my career as a detective, I've learned that accountability is key to justice. Yet, on the issue we speak of today, accountability is missing. Costs continue to rise unchecked, opaque billing practices are the norm, and those tasked with running self-funded health plans for tens of millions of people are regularly blockaded and stonewalled from information that would give them a fighting chance. For those of us serving in uniform, this is more than a financial burden, it's a betrayal of the trust and security we as officers strive to provide and uphold. I'd be remiss if I didn't mention the countless members of the healthcare community who have been blazing the path for transparency and accountability far in front of me and who have brought me along this journey. People like Cynthia Fisher, an advocate for price transparency, Dr. Susan Hayes, who was a pioneer in pharmacy benefit managers reform, and especially my friend and colleague, Kristen Deacon, who's here with me. They're both fearless in their endeavors and the most zealous advocates for consumers and payers I've met along this journey. I stand before you today not only as a retired police officer and labor representative, but also as a husband, father, and grandfather, and I implore this committee to recognize the urgency of health care reform. We, the everyday Americans, the officers who serve our communities, and the public sector workers who keep our society functioning, don't have the deep pockets to lobby Washington. Yet our needs and voices are just as important. This is why I'm here today, to remind you of the countless families like my own.
Thank you. Thank you. Thank you. Thank you for your service, and thank you for your testimony.
Thank you.
The chair now recognizes Ms. Tripoli for 5 minutes for opening statement.
Good morning. Chairman Guthrie, Ranking Member Eshoo, members of the committee. Thank you for the opportunity to testify today. It is an honor to be with you. On behalf of Families USA, a leading national, nonpartisan voice for healthcare consumers, working to ensure the best health and healthcare are equally accessible and affordable to all, I want to thank you for this critical discussion, as well as Chair McMorris-Rogers and Ranking Member Pallone for your collective leadership in advancing bipartisan solutions to improve healthcare affordability and price transparency. Today's hearing is urgently needed. Our healthcare system is in crisis, evidenced by a lack of affordability and poor quality. Every person in the United States should have high-quality healthcare that prevents illness, allows them to see a doctor when needed, and keeps their family healthy at a price they can afford. Yet high and rising healthcare costs are eroding the economic freedom of American families right before our eyes. We can't afford to retire when we want, send our children to college, or even meet basic needs like paying for rent or heat. Almost half of all Americans forego medical care due to the costs. A third say that the cost affects their ability to secure basic necessities like buying groceries. And over 40% of American adults, 100 million people, face medical debt. Rising healthcare costs are a critical problem for national and state governments and affect the economic vitality of middle class and working families by crippling the ability of working people to earn a living wage. As a nation, we spend more than $4 trillion per year on healthcare, yet our health is not better. Our moms and babies die at higher rates, and 250,000 people are killed by the healthcare system each year from medical errors, infections, and the like. Every American knows that we pay too much for the quality of healthcare that we get. This crisis is driven by a misalignment between the business interests of the healthcare sector and the health and financial security of our nation's families. Our system allows the healthcare sector to siphon money out of workers' paychecks and taxpayer pockets and into building C-suites of big healthcare corporations to increase healthcare prices. We reward building medical monopolies and price gouging instead of ensuring the health and well-being of our nation's families. Healthcare industry consolidation has eliminated competition and allowed monopolistic pricing to push our families to the brink of financial ruin. Nowhere is this clearer than when looking at the price of hospital care, which accounts for 30% of U.S. healthcare spending. That's $1.4 trillion annually. Since 1990, hospital prices have increased 600%, and just since 2015, they've increased 31% nationally, growing 4 times faster than workers' paychecks. These prices are not only high, but they're irrational. An MRI at a single hospital in Boston, Massachusetts costs 5 times more just depending on the insurance carrier. Or take the average price of a knee replacement, which costs 3 times more in Sacramento, California than in Tucson, Arizona. These higher prices are passed on to families as annual increases in insurance premiums, abusive facility fees, and higher cost sharing, and become profit margins for large healthcare corporations. But it doesn't have to be this way. We know what's driving the crisis and how to fix it. The PATIENT Act, which this committee advanced in May 2023, and the Lower Cost, More Transparency Act, which this committee played a leading role in drafting and which passed the House of Representatives in an overwhelming bipartisan vote in December of 2023, would both make crucial progress by codifying and strengthening price transparency rules, expanding site-neutral payments, and advancing billing transparency, among other reforms. Congress has enormous public support to do this. Nearly 90% of voters want Congress to act to reduce hospital prices, including 95% of Biden voters and 85% of Trump voters. I'd like to finish my remarks with the story of Brittany Tesso and her son, Roman, from Aurora, Colorado. Roman's pediatrician referred him to a hospital to receive an evaluation for speech therapy. Because it was the height of the COVID-19 pandemic, the Tessos met with the panel specialists via video conference. They observed Roman speaking, playing, and eating. Later, Ms. Tesso received a $700 bill for the 1-hour video appointment. Then she received another bill for nearly $1,000. Thinking it was a mistake, Mrs. Tesso called the hospital. And despite the fact that the Tessos never stepped foot inside the hospital, she was told that the bill was a facility fee designed to cover the cost of being seen in a hospital-based setting. This is a national scandal. We urge this committee to continue working with your colleagues in the House and Senate to stand with the American people and enact legislation to stop pricing abuses driven by big healthcare corporations. I thank the committee for your time and your dedication to these issues and look forward to answering any questions.
Thank you for your testimony. I appreciate it. Dr. White, you're now recognized for 5 minutes.
Chairman Guthrie, Ranking Member Eshoo, and members of the subcommittee, I appreciate the opportunity to appear before you today. In consultation with committee staff, I have focused the statement on federal subsidies for health insurance coverage, the growth of those subsidies, and policy approaches that could reduce health insurance subsidies and the federal deficit. Thank you, sir. The federal government subsidizes health insurance for almost all of the U.S. population through some combination of Medicare, Medicaid, and various tax provisions. Those tax provisions include allowing employers and employees to exclude payments for health insurance premiums from income and payroll taxes, and by providing premium tax credits through the ACA marketplaces. The CBO projected that in fiscal year 2023, those subsidies would amount to, on net, $1.8 trillion, equal to 7% of GDP. Federal subsidies for health insurance are projected over the next 10 years to total $25 trillion. That includes $11.7 trillion for Medicare, $6.3 trillion for Medicaid and CHIP, $5.3 trillion for employment-based coverage, and $1.1 trillion for the ACA marketplaces. Partly because of those subsidies, federal outlays over the next 3 decades are projected to grow faster than revenues, leading to ever larger deficits and debt. CBO projects that under current law, outlays for the major federal health programs would increase from 5.8% of GDP in 2023 to 8.6% in 2053. At the same time, rising premiums for employment-based coverage will reduce the share of employees' compensation subject to taxes, thereby decreasing federal tax revenues. Federal subsidies for Medicare and employment-based coverage are projected to increase as a percentage of GDP from 2023 to 2033. The size of those subsidies depends on 2 factors: the average subsidy per enrollee and the number of enrollees. In Medicare, CBO projects that under current law, the subsidy per enrollee will grow by 5% a year, and enrollment will grow by 2% a year. For employment-based insurance, the average federal subsidy is projected to grow by 7% a year, and enrollment is projected only to grow by 0.5% a year. So in Medicare, it's largely an enrollment story. For employer-sponsored insurance, it's largely a subsidy per enrollee. The prices that commercial health insurers pay providers tend to rise faster than the prices paid by government programs such as Medicare and Medicaid, whose prices are generally set administratively. CBO estimated that between 2013 and 2018, the prices paid by commercial insurers grew by an average of 2.7% a year, whereas the prices paid by Medicare and the fee-for-service program grew by an average of 1.3% a year. That was partly using HCCI data. Besides growing faster, the average prices that commercial insurers pay for hospitals and physician services have historically been higher than the prices paid by the Medicare fee-for-service program. Those higher prices result from several factors, primarily the market power of providers and the limited sensitivity of consumers and employers to the prices that insurers pay. Government policies can reduce the high prices paid by commercial insurers by targeting the factors that contribute to those prices, although many of the underlying causes are not amenable to change by federal legislative action. In CBO's assessment, a comprehensive set of policies that promoted price transparency would lead to price reductions between 0.1% and 1%, and a comprehensive set of policies that promoted competition among providers would lead to price reductions of 1% to 3%. Price reductions of 3% to 5% or more would be possible under policies that capped the level or growth of prices paid to providers. CBO expects that reductions in prices paid by commercial plans for hospitals and physician services would reduce premiums for employment-based plans, which in turn increases employees' taxable wages and federal revenues and decreases the deficit. CBO analyzed an illustrative policy that would lower prices for hospitals and physician services by 1% and found that in the year 2032, it would shrink the federal deficit by $4.8 billion, mainly by reducing federal subsidies for employment-based insurance. I look forward to the conversation.
Thank you, gentlemen. It's concluded all the testimony. Thank you for your testimony. It's concluded all testimony from our witnesses, and we will now move into members' questions. And we'll each have 5 minutes for questions, and I will recognize myself to start the questioning for 5 minutes. So, Dr. Ippolito, you talked about, I got coffee sitting here, talked about the coffee shop scenario, and I use that quite a bit. So if you said Starbucks and another coffee, either sit next door or across the street, Starbucks would have to lower prices or change its, be more efficient. Well, that assumes the person walking down the street knows how much the coffee is between each store. So if you don't know what the price is, you just walk in, you get a cup of coffee and you walk out, and a month later, somebody tells you how much you had to pay for it. I mean, that's kind of the system that we have. That's what we're trying to figure out. And if we can get into that part of it, then we'll know, because Ms. Tripoli said that some people pay 5 times more than others. What if you're standing in a coffee shop and you get a coffee for $10 and the guy behind you or the lady behind you pays $2? You're going to look at it and say, wait a minute, you just paid $2 and I just paid $10? That's what the Lower Cost Transparency Act on both sides of the aisle wants to expose and let people find out and make decisions moving forward. And so thank you for that example. So I know that we have other things trying to control costs. So because what I envision if we do this is that the employer, the labor groups, others who provide this insurance are going to say, I'm not going to pay that if the other person's not paying. So it drives the cost. But Congress does try to put in, I don't know if price controls is the right word, but so the medical loss ratio from the Affordable Care Act would be an example to try to control costs. The idea is you got to pay out more than you can't do this to us, you got to pay out more. I think they find other ways to move their money around to get around that. Would you talk about the medical loss ratio and what it has done to healthcare prices?
Yeah, I mean, the problem with the medical loss ratio is there's two ways to meet it. You can either lower your premiums, or you can just let your costs rise and not worry about them so much. And I know there's at least one paper out there that suggests that following the ACA, a bunch of insurers just went ahead and let their claims costs rise, and they didn't actually lower their premiums very much. So there is evidence to that point. And to your second point that you raise, this MLR type regulation gets harder in the current world where we have more vertically integrated entities. If an insurer owns a PBM and a pharmacy, they have a lot of leeway about how money moves through that chain. And if you've got to meet an MLR threshold, you can decide to move the money in a way that's convenient for you and meet the threshold. And so suddenly it kind of becomes relatively toothless.
Well, if you're not vertically integrated, does it incentivize you to become that? So if you're a health insurance company and you're having MLR, do they say, well, let's go buy up or downstream so we can?
Well, potentially, and this is sort of a second concern, which is that if you're the vertically integrated entity, you've got an incentive to really screw over the other guys. So you tell your PBM, charge them more than you charge me to make it harder for them to meet that threshold, right? And so it's
Well, thanks. I want to move to Dr. White on subsidies. I know that the idea is to get more people covered. Health insurance continues to rise, so the more you subsidize. I go from the coffee exhibit to college tuition and so forth, and I just went through 3 kids going through college. And it seems like, I know people have done studies and they try to say that college tuition doesn't tie directly to subsidies, but I will tell you there are people who I've seen sitting there, and I'm fortunate to have some assets and didn't face this, that are completely priced out of the college their kid wanted to go to. And sitting there going, I'm not sure if my kid's gonna be able to go here. I gotta sit down and crunch the numbers and move forward. And it seems you're either on the subsidy side, which aren't really sufficient, or you're able to pay, or you're stuck in the middle. And it seems we have a lot of people stuck in the middle. That's happening with healthcare as well. Would you talk about the relationship between do subsidies do anything to lower prices that sponsor plans pay? And what impacts do rising healthcare costs have on wages? And your microphone.
Thank you. So in terms of the subsidies as they relate to the prices that the plans pay, I think there are 2 markets to talk about. One is the employment-based market, where all of the premiums paid are excluded from taxable wages. And that is a sizable subsidy for employment-based insurance. And when employers are thinking about the breadth of their network, which providers to include in their network, thinking about benefit design broadly, that tax subsidy puts a pretty heavy thumb on the scale to broadening the network, including more providers, and it eases the pressure to reduce costs for employment-based plans across the board. And my understanding of the market and the evidence is that that's going to have some impact on the prices that employment-based plans pay.
We have about 5 seconds, and the whole purpose of this hearing is talking about the rising costs, because we can't subsidize our way out of it. We have to deal with the rising costs of the system. But we want more people to be covered and have access, so that's where we have to focus as moving forward. Thank you. My time has expired. I'll yield back and recognize the gentlelady from California for 5 minutes.
Thank you, Mr. Chairman, and thank you to each one of the witnesses. I feel overwhelmed. And I think I would best describe this as trying to get socks on an octopus. I mean, this is, there are so many layers to all of this. So I know it's not easy to simplify, but I would ask each one of you to identify a cost savings that really puts a dent in the system. I mean, you've done a marvelous job of telling us all the things that are broken. And, you know, the stories from consumers, all of that. Hardworking law enforcement people. I mean, this affects everyone. Everyone. No one skates away from this. We're human beings, our bodies need care, some need more depending on their age, some are afflicted with serious illnesses, others really don't even get to pay down their deductible because they don't use that much in healthcare, and yet they're paying through the nose. So why don't we start with you on the left here?
I would
One
say
thing. One thing.
increasing competition, reducing consolidation.
In the short term, site-neutral payments or reforming Medicare Advantage.
That what? I'm sorry.
In the short term, either site-neutral payments in Medicare or trying to reform Medicare Advantage a little bit.
Access to claims data so we can tell what we're paying for services.
And do you think that the legislation that we have passed in the House addresses that fully?
Ranking member, I am cautiously optimistic, but you talked about an octopus. That's how I refer to the Hospital Association. They'll figure a way around it.
I would say, without a doubt, price transparency in the short term and enacting site-neutral payments, real savings to people right now, and then we work towards longer-term solutions around building, reducing consolidation, improving competition in the markets.
What do you think the site neutral addressing that issue, what's your estimate of reducing overall costs?
My understanding from the estimates is there's a range, but it's about $150 billion over 10 years for a comprehensive site-neutral package to what the Medicare Advisory Payment Commission is recommending. And then that includes about $94 billion in savings directly to Medicare beneficiaries.
And CBO doesn't recommend policy. We don't advocate for policy. But in the score of the Lower Cost, More Transparency Act, expanding site-neutral payments in Medicare is a saver. Increased transparency is a saver on many dimensions. And the site-neutral policy that's in Lower Cost, More Transparency is pretty narrow, but the more expansive version of site-neutral policy we expect could have some dampening of the incentives to consolidate, and that could spill over to what commercial insurers pay and negotiating leverage.
Dr. White, I want to thank you and CBO's Office of Health Analysis for your superb work. You and your staff have lent really tremendous expertise to my office, and I think that you're an invaluable part of the legislative process. So all of my thanks to you. Thank you to each one of the witnesses. We, you know, the price tags that we've called out in our opening statements, what you all have referred to in some part of your testimony, seems so overwhelming. And yet I'm struck by piece, 1%, 2%, 3%, in terms of projected savings, you know, depending on what it may be. So it seems to me that there's not one blockbuster policy that is going to, you know, move us in the direction that we all want to move to. I think it's a series of them, but thank you for being here. Thank you for your testimony. I yield back.
Can I have
Mr.
your
Chairman.
7 seconds?
Sure.
So we have to also balance as we deal with this. We do have the best hospital system in the world, so it's a lot of things we have to factor in as we move forward. The gentlelady yields back. The chair recognizes the chair of the full committee, Ms. Rogers, for 5 minutes.
Thank you, Mr. Chairman. As we have worked on price transparency in healthcare, I have said that it is foundational to restoring the doctor-patient relationship and decision-making in our healthcare system. It also is foundational to addressing what the actual costs are, for us to know what the actual prices are, the cost, and then to be able to take action. And as representatives, you know, 70% of the federal government spending now is healthcare. So if you think about double-digit increases in healthcare spending in the federal government and what's driving deficits and debt, I mean, answering this question and for us to better understand what the actual prices are and the cost is just foundational across the board. I personally know of someone in my district who has spoken to me. She's actively putting off a needed eye healthcare because she cannot get anyone to give her an upfront cost estimate. Price transparency needs to be the standard throughout the healthcare system. This is the way that we're going to restore doctor-patient relationship and address what's driving cost. Ranking Member Pallone and I recently applauded the Centers for Medicare and Medicaid Services announcement to finally implement prescription drug price transparency, which our bill would improve and make the law of the land. So Dr. Ippolito, sorry about that. Do you believe that prescription drug price transparency will help lower drug prices?
In general, yeah, and in particular with respect to what's included in the bill that we're talking about, I tend to agree with CBO's assessment. I shouldn't point there, but I tend to agree with their assessment that if you give employers in particular more information about how they're spending their money, how their formularies are made, then they're going to make better decisions on average. So yes, the short answer.
Thank you. Ms. Tripoli, in our Lower Cost, More Transparency Act, we took modest but critical steps towards site-neutral payments by implementing them for drug administration services. So in other words, Medicare and patients will pay the same prices regardless of whether or not a hospital owns the outpatient office where the drug is provided to the patient. The hospital community has argued vigorously against site-neutral payments, while there seems to be significant bipartisan agreement among some experts that site-neutral reforms are the right thing to do to lower seniors' costs and address potential incentives for consolidation. Would you talk about the importance of site-neutral payments to patients?
Absolutely. I think site-neutral payments essentially address this broken economic incentive in Medicare reimbursement, which reimburses for the same service at a higher cost and a higher cost care setting than it does in a physician's office. That incentive not only creates a financial incentive for big hospital systems to come in and buy up small and independent physicians' offices, rebrand them as an outpatient department so they can generate a higher reimbursement, but it also pushes patients into higher cost care settings. Both of those factors together have the effect of increasing costs, increasing prices in the healthcare system. So addressing this Medicare payment differential, the site of service differential, through site-neutral payments is critical to not only reducing the incentives for hospitals to buy up local doctors, but also helps keep patients in a lower cost care setting where the quality of care is the same or better.
Thank you. Dr. Ippolito, your testimony discussed some of the arguments around site-neutral payments, and you noted the Drug Administration Policy and the Lower Cost, More Transparency Act is important but narrow. And I just would like to make clear that the site-neutral conversation is not an exercise in cutting hospitals. It's really about how to more efficiently structure Medicare so that patients and taxpayers are not overpaying for the same services to subsidize lost leaders. So would you talk a little bit more about comprehensive site-neutral policies, how they could be structured to preserve our very important hospital safety net while fixing the very real problem we've identified?
Yeah, so one of the important things to remember is that if you fix site-neutral payments, you have this big spillover into markets outside of Medicare. It reduces the incentive for hospitals to buy up all these independent physicians, which increases costs for everybody on commercial insurance. So if you address site-neutral payments, you have this big spillover effect. If you do a more comprehensive policy and have more meaningful concerns about the viability of certain hospitals, it would be far better to go ahead and do site-neutral payments and come up with a policy that directly addresses those hospitals you are concerned about, not keep the current policy that overpays everybody for these services in an attempt to help this subset. Try and directly address them, either subsidize them directly or limit the losses from the policy for those specific hospitals.
Thank you. Thank you all for being here. My time has expired. I yield back, Mr. Chairman.
Gentlelady yields back. The chair now recognizes the ranking member of the full committee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I heard you say that we have the best hospitals in the world, but it's not necessarily meaningful without access, and too many families have to delay or forego necessary care due to cost. And our healthcare system is complex, and often patients cannot see in advance the prices they have to pay and have to wait until after they receive medical care and have the bill to fully understand how much they owe. And to me, that's unacceptable. So let me start with Mr. Lyons. In your testimony, you discussed the need for greater transparency. Can you briefly discuss the difficulties you faced in navigating our health system?
Thank you, and good Good to see you from the Jersey Shore, too.
Oh, you too, thank you. He's a New Jersey guy, just so you know.
Within my role at a state health benefits plan, one of our biggest problems is not only getting the hospital prices, but being able to match it to the claims data, right? So we need to be able to see both ends of the equation, because if you just get one, you don't know the other one to make sure everything's lining up. And we do have instances where we see things are paid over the contracted rate to the hospitals. So I think when we get blocked to get information, and I have data requests out from probably 3 years ago that I still haven't gotten. I still haven't received the data, claims data that we wanted, because the hospitals and the insurers come together and say, that's proprietary. We can't tell you what we're paying. Well, I'm a special state officer when I sit on that committee. I should have full access to that so I can make the right decisions, just like you do for the people of the country. I need to do it for the people in my plan. So essentially, just open access to claims data for the payers. You know, I'm not saying it has to be, you know, the insurers' numbers have to be posted on the internet, and then what the contracted rate is, so we can match that up and make sure, you know, Ronald Reagan said it, trust but verify, right? So that's what we should be able to do.
And then my second question, if you just describe specifically how strengthening transparency can help lower healthcare costs for patients. I mean, you sort of got into that, but if you wanna elaborate.
For us, we're looking at a centers of excellence model right now, right? So there's two sides to that in my eyes. One is quality and one is cost. So if we can pair them up and know what we're paying. I just talked to a reporter who said he looked at a hospital's website in New Jersey. They posted their prices, 300,000 lines of data. Who's supposed to dig that out? You know, we're still lay people at the end of the day. So I think, you know, what you're doing here really helps us take those first steps. And I think when people see the prices and the price differentials, it's going to shock the conscience, and people, and that'll start the tide rolling the right way.
No, and I appreciate all your efforts. I mean, you know, the hospitals just continue to make it difficult for consumers to access price information, and, you know, there's low hospital compliance with the reporting. But let me go to Ms. Martin. Can you briefly discuss how employers are currently using the transparency data to achieve savings, and how increased transparency can help employers?
I think employers are having a hard time using the currently available transparency data, to the point that he just made. It's a lot of information, it's difficult to parse, it's at varying levels. But I think the opportunity is there so that with additional data, they can create strategic networks, strategic negotiations. They would be empowered to negotiate for health services the way they do for other input costs.
All right, well, thank you. And, you know, I'm obviously proud of the committee having passed the Lower Cost, More Transparency Act, because I think it will deliver lower healthcare costs for the American people and bring a lot more transparency to our complex healthcare system. So I want to thank all of you. I have to, Mr. Chairman, I was laughing because when you asked Dr. Ippolito how to pronounce his name, and he told you, you know, we have another hearing going on about sports upstairs, and I have no problem pronouncing your name because when I was in high school, Coach Ippolito was the coach of our champion high school football team. So I'm very fond of the name. Thank you, Mr. Chairman.
He wasn't a tough football coach? No. We all loved our coaches, but boy, sometimes we didn't. So thank you very much. So the gentleman yields back. The chair will now recognize Dr. Burgess for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you for holding this hearing. It is critically important. Once again, I will bemoan the fact that we don't have a physician on the panel. One of these days, I'm going to walk into one of these hearings. We're going to have 6 doctors tell us how much economists should be paid. But that's a fantasy that I'll save for another day. I do want to answer quickly Mrs. Eshu's question about an answer, and I've brought it up to this committee before. We have a bill that's ready to be marked up, and that involves physician ownership of hospitals, particularly in rural and underserved areas. There is an answer to consolidation. There's competition. Physician-owned hospitals would provide that. There is no reason to allow the PBMs and the private equity and real estate investment trusts to control all of the money in healthcare. We could leave some of it for the doctors and the patients. We've heard it several times today, whether you're talking about the GDP or the percentage of the federal budget, it is a big number, and it's clear that we as policymakers need to do something now to curb those costs. Across the campus in the Cannon Building, in the Budget Committee that I also serve on, the Budget Committee's created a healthcare task force to serve as an incubator for ideas, for some of these ideas to lower costs, working to examine the causes of excessive spending and propose solutions without sacrificing patient outcomes. And we've already seen really an overwhelming response to our request for proposals with 180 submissions to that task force, demonstrating the pent-up demand that exists. And on that task force, we had a roundtable bringing relevant stakeholders to the table with the Congressional Budget Office to discuss the Congressional Budget Office's scoring of mandatory drug pricing in the Inflation Reduction Act. There's some discrepancy between the number of new drugs that CBO said would be produced and people who lived in the investment world and the research world had different ideas to try to bring those together. And to tell you the truth, it was successful because the CBO now has opened a portal on their website for stakeholders to submit research and data they have regarding the cost of the reality of drug innovation. So it just goes to show that it's possible to have more than a conversation about these difficult issues. You can, in fact, affect the way policy is done. I do have a letter that I want to introduce to the record, responding to the CBO's call for new research in the area of drug development.
Thank you. We'll take care of that at the end of the hearing. We'll make sure that's distributed.
And this response letter is signed by more than 350 biotech investors and innovators representing $309 billion in assets under management. Mr. Lyons, I feel your pain. As a senior member of Congress, I cannot get claims data from the Center for Medicare and Medicaid Services, which is, after all, a governmental body, and you would think Congress, which created CMS, could get the claims data, but we can't, and that has been a frustration of mine literally for over a decade. The other thing I have to bring up, I was on a very, very difficult telephone call last night, a Zoom call late last night with physicians all over the country. And I will tell you, our physicians are discouraged. They are looking for the exit ramps from the practice of medicine. We've caused this in Congress because we've made it more attractive for the private equity buyouts of hospitals and doctor practices. We've made that more attractive than actually paying physicians. This January, physicians got an almost 4% pay cut. That's in the face of an 8-9% inflation rate last year. So what I'm hearing, and I'm sure many on this committee are hearing, is the doctors just simply cannot sustain that. The cost of their employees, none of their help comes to them and says, you know what, I realize you took a pay cut, I'll take a pay cut too. Well, the world doesn't work like that. So the doctors do need relief. I've got a Politico article I'm going to introduce that has an unfortunate title, Doctors Just Want a Pay Raise, but really the understanding that the issue of provider reimbursement is important. If we are going, one thing to talk about the cost of and the quality of care we have available, but if we've got no one to deliver the care, it's still going to be unattainable for the patient. So we on this committee do need to pay attention to that. And again, I'm going to ask that the Politico article also submit that, you'd ask unanimous consent that that be part of the record. I apologize that I used all my time to pontificate. I have a number of questions I'm going to be sending to each of you that I'll ask for those responses to be on the record. Thank you, Mr. Chairman.
Thank you, Dr. Burgess. Goes back. Without objection, we'll add this to the documents list that we'll act on at the end of the committee if they're not already submitted. So if anybody wants to review those, please let us know before the end. The chair now recognizes Mr. Cardenas for 5 minutes for questions.
Thank you, Chairman Guthrie, and also Ranking Member Eshoo for holding this very important hearing. And I want to thank the witnesses for being here to give us your expert testimony and opinions today. It's very important that the public know what we're deliberating and why we're deliberating it, and hopefully we can do it based on fact and not on other issues. And I also want to say I agree with Dr. Burgess, Congressman Burgess, about physician-owned hospitals. We need to visit that. We shouldn't be assuming that physician-owned hospitals cannot follow the rules. In this country, we allow lawyers to own their own law firms, so it's unbelievable to me that we'll trust lawyers more than doctors to do the right thing. This committee has done a good amount of work on improving transparency in the health ecosystem and lowering costs for patients. I'm proud of that work, and I'm glad that we're getting a chance to continue this conversation today. For too long, we as Americans have gotten completely unacceptable return on our investment when it comes to our health care. Hardworking Americans are scraping by, often delaying or foregoing care because they know they will be forced to pay untenable prices for their health care services. And what do we get back in the end? Dismal health outcomes and widening health disparities. One study found that the U.S. has the lowest expectancy at birth, the highest avoidable death rates, and the highest rates of maternal and infant mortality compared to other high-income countries around the world. All of this despite health expenditures being 2 to 3 times higher here in the United States. I urge my colleagues to think about what this means for the people in every single one of our districts. Let's say you're a single parent in Sylmar, in my district. You have no idea how much your care is going to cost, and you're already struggling to make ends meet. Do you risk it and go to the doctor not knowing how much it'll cost you, or do you hope your issue resolves itself? This is why transparency is so critical. It gives people the power to choose where, when, and how they seek their care. This is particularly critical for people seeking preventative care before a medical issue becomes unavoidable or untenable, when it will still be less expensive to address. But transparency is also only as good as the choices people have. Transparency is a great start, but I want to focus my questions on what comes next and ensuring choices in care settings. Ms. Tripoli, what steps can be taken to improve patient choice past the initial step of improving transparency?
Well, I think part of the focus, obviously, of this hearing is talking about how we can empower consumers and patients, employers, workers with more information to make more informed decisions. Price transparency, not only for hospitals and for plans, but across the entire healthcare system, transparency of information is going to be critical to unveil the curtain of what is happening underneath the system that's driving unaffordable care and low quality care, frankly. So I think price transparency for sure, for hospitals and plans, also many of these provisions, obviously in the Lower Cost, More Transparency Act, enacting site-neutral payments, which gets underneath the hood if the healthcare system takes on this broken financial incentive. That allows consumers to have, whether you're in Medicare or you're in the private market, to have more affordable care options. Those are probably two of the most important provisions that this committee has advanced through this legislation.
How can we ensure we build out care options in medically underserved communities where there's less financial incentive to provide services in that community?
I think it's a balance. We have to make sure that the community-based providers that are in these communities are financially sustainable. We have to make sure that the markets function for them. We have to make sure that care is affordable, and that the people that they are designed to serve have options, have choice, and there are a whole variety of policy solutions that we need to address to make sure that people in communities have access to what they need.
And how do the, quote, broken financial incentives you mentioned in your testimony disproportionately fall on the backs of poor communities and communities of color?
I think consolidation in the healthcare system affects every single community across the country, and the way that the involvement of private equity in mergers and acquisitions and the impact that has on reducing wages, on reducing access, even closing the doors of certain hospitals has a direct impact on some of the communities who are most hard hit, who need services the most. So we have to have a holistic approach when we're thinking about making sure we have access for all.
Thank you. I look forward to continuing the effort of trying to improve access to quality, affordable health care for all Americans through the work that we do in this committee. Thank you, Mr. Chairman. I yield back.
Thank you. The gentleman yields back, and the chair recognizes Mr. Griffith for 5 minutes.
Thank you very much, Mr. Chairman. Let me join Dr. Burgess and Dr. Cardenas as a lawyer who believes that physician-owned hospitals is probably not a bad idea and probably a good idea, particularly since in my hometown we have the Lewis Gale Hospital, now owned by a larger corporation, but started out many, many years ago by Doctors Lewis and Doctors Gale, and then revived in my childhood by doctors that I knew. They were physician-owned hospitals, and there's a lot of communities in my area that would not have a hospital today if it hadn't been for physicians a long time ago. And for many years, I owned my own law practice, and I drove down the costs of various items, particularly wills and representation in small traffic cases, because I liked helping people, and I think doctors can do the same kind of stuff. That being said, let me get you all to put on your common sense hats, take off your professional hats for just a second, and I'm going to start with Ms. Martin. We're going to go down to a yes or no. Am I correct that it's probably cheaper to treat a person with cancer if we catch it in stage 1 or 2 versus stage 3 or 4? Yes or no?
Yes.
Dr. Ippolito.
Potentially, yes.
Mr. Lyons.
Yes.
Dr. White.
It depends.
It depends.
That's a CBO answer.
Well, I know, but this is where I was going. And I didn't want to just pick on you,
Go for it.
but I have a problem with the way CBO scores things. And we have a bill in front of the House right now. It's in the process, H.R. 2407, which was an idea that Mr. Hudson came up with, Mr. Arrington and Ms. Sewell are carrying. It's a bipartisan bill. And it says we're gonna say you're gonna pay for the multi-cancer test that you can get, and that's about $1,000 now. But we can pick up early stage cancers in 50 different types of cancers. Now, it doesn't tell you, you've got cancer A or cancer B, but this test will tell you, you have some kind of cancer, and we can narrow it down for you, but you better go see somebody to check it out. And to me, this would save us money. Now, I know it's not the formulas that you all use, Dr. White, but can't you see there's some advantage? And what do we need to do as Congress to give you the formula that would allow you to see that there's actually a cost savings? Taking the test is going to cost money. But in the long term, if 10% of the people that we paid to have a test done this year found they had a stage 1 cancer, it's going to save us every bit of that money in the long term. So, A, do you agree with me? B, is there some way we can change the formulas that you all use or give you the authority to look at where the cost savings would be?
Sure, and I appreciate the question. So first, let me say CBO in late 2020 put out a report on how we score prevention, and the multi-cancer early detection is a nice example of the types of prevention policies that we've written up and analyzed. And one of the key landmark studies that we cite in that comes from a group at Tufts that has looked at literally hundreds of studies on prevention.
So you see some advantages, because my time's running out, you see some advantages with that kind of a preventive tool, and you're willing to work with us to figure out how we can make that most effective for the people of the United States, because that will lower costs.
We're very open to hearing from.
Next question, not prevention, but just using practical CBO scoring. I've always had this issue with ambulance rides. So I'm a big proponent of telemedicine. And while telemedicine won't solve everything, I represent a very rural district. And if we have somebody who has to go see the doctor, it could be done by telemedicine, you might have a 40-mile, that translates, by the way, because the roads are windy and mountainous, that translates into an hour to an hour and a half ambulance ride to go see the doctor when you could do it by telemedicine. Help me figure out that formula so that you all can give credit when we know that we're going to reduce the number of ambulance trips that would allow us to do telemedicine in certain cases. It's not going to be appropriate in all cases. That too would lower costs if we were able to calculate that, would it not? Yes or no?
We have a team working on telehealth, looking, and what you're saying about ambulance rides being avoided, that's the kind of thing that we're looking at. We're building our own evidence base, and happy to hear any.
No, I appreciate that, because
evidence you have.
You can't just look at the flat land sections of the country and come up with a model, because it's not going to save as much money in a big city. It's not going to save as much money in the flatlands. But when I have a mayor of one of my towns has told me that he will drive to Abingdon instead of going to the town closest to him for medical stuff because it's an hour over the mountain, to get to the next. Now, on a map, it looks like it's, just this far, and Abingdon looks like it's this far, a lot further. But there's a good road and it's flat, or it's less flat, or less mountains. So it goes the other direction. When I've had that happen, and I know that makes a difference, those ambulance rides are doing the same thing, and they're costing us a bunch of money.
Thanks, Mr.
I appreciate it. I yield back.
All right, thanks. Thank you for yielding. The gentleman yields back. The chair now recognizes Dr. Ruiz from California for 5 minutes for questions.
Thank you, Mr. Chairman. We need a healthcare system that allows everyone to get the care they need when they need it, regardless of where they live or how much money they make. That is why I'm in Congress, to enact real change to protect patients and better their access to affordable care. As an emergency medicine physician, I have treated patients who made the difficult decision to delay seeking medical care because they couldn't afford it until their condition worsened and came into the emergency department. While we have made progress in recent years in improving our nation's healthcare system, there is much work to do to remove barriers to high-quality care. And as this hearing today underscores, one of the biggest barriers is cost. Research has shown that consolidation in the healthcare system leads to higher costs of care and affects physicians who want to remain independent. Not only that, but consolidation has also been shown to lead to worse health outcomes for patients. Local independent practices are sometimes a patient's closest healthcare option in rural or underserved areas. Ms. Tripoli, in your written statement, you referenced the fact that the percentage of physician practices that were hospital-owned rose from 15% to 53% from 2013 to 2021, and nearly 23,000 physicians left independent practice to work for a hospital or other corporate entity after the COVID-19 pandemic. That decrease in competition drives up healthcare costs. In your opinion, what factors are leading more and more physicians to leave their independent practices?
There are probably several, but the two I'll focus on is the first is that we vastly, significantly undervalue and therefore underpay primary care and behavioral health providers, which disproportionately make up a lot of independent physician practices. And the result of that, they are financially vulnerable. And the second is we have these incredibly broken financial incentives where we, site of service payment differentials that actually have this incentive for big systems, hospitals to come in and buy up physician practices, the independent physician practices, rebrand those practices as outpatient departments so that the hospital system can generate a higher reimbursement. And those two factors, has particularly been accelerated from the COVID-19 pandemic, where the financial vulnerabilities of these independent practices were hit very hard. Primary care nearly collapsed. And so I think a policy like site-neutral payments helps to address some of those problems at the root. From site-neutral payments, you can actually take some of that savings and reinvest it to increase investments in the very physicians, primary care, behavioral health that we need on the front lines of the healthcare system.
Thank you. For years, physicians have been experiencing cuts to their Medicare reimbursements, even while other Medicare providers have experienced increases for inflation. From 2001 to 2023, inflation-adjusted payments for physicians declined by 26%, even amid the rising costs of running a medical practice. On top of that, physicians are facing a 3.37% cut this year unless Congress takes action. We can't afford for more independent practices to close their doors or to take fewer Medicare patients because they can't afford to treat them. When physicians leave to join large hospital systems, this can create barriers to care for our most vulnerable patients, especially in rural areas that often bear the brunt of healthcare workforce shortages. A major way Congress can address rising healthcare costs stemming from consolidation across the healthcare system is updating the Medicare physician fee schedule. Ensuring appropriate Medicare reimbursements would reduce the strain and burnout on independent practices and help reduce the trend of consolidation. My bill with Congressman Bouchon, the Strengthening Medicare for Patients and Providers Act, would do just that. And we should also be investing in residency programs like teaching health center graduate medical education to develop a healthcare workforce that stays in the area where they are needed the most. Oftentimes, if a patient is out of network, insurance companies underpay what the cost of that care was for that patient. When you have small practices that can't negotiate at the negotiating table with large multi-state national insurance companies, then they are vulnerable to a take-it-or-leave-it type of negotiating practices because if they don't take it, it doesn't really matter for the insurance companies. So I think that our no-surprise billing law that we passed which had the independent arbitrator, baseball star arbitration for my bill, helped to avoid patients getting surprise billing. But we still have work to do to help providers be at an equal negotiating level with insurance companies so that they can get a fair reimbursement for out-of-network costs. What other ideas do you have that could help us improve patient care and access to care as we've discussed? Yes.
I completely agree. Protection and ongoing implementation of the No Surprises Act is critical. I think in terms of lowering costs, making sure that we're not only addressing high hospital prices and many of the solutions that this committee has advanced in the Lower Cost, More Transparency Act around price transparency, site-neutral payments, transparency across the healthcare system around PE ownership, and also continued implementation of the Inflation Reduction Act. We know that drug prices continue to go up. That has been a hugely important piece of legislation now being implemented. As Medicare begins negotiating those drugs, we're going to see drug prices come down, and that will result in direct affordability for the American people.
Thank you.
Thank you. The gentleman yields back. The chair now recognizes Mr. Bilirakis from Florida for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it. Dr. White, recent reporting has discussed higher incidence of cancer among younger Americans, unfortunately. To the extent this represents better and earlier detection, this is a good thing, but I fear that's not necessarily the case. This shines an important light on the need for better, earlier, and more efficient detection of cancers and other deadly diseases. How can we incentivize better use of preventive services that ultimately lead to save money in the long run? Whether that, and I know that my good friend over here, Morgan, discussed this with you, whether that be through new screening technologies or finding ways to prevent hospitalization. If you could elaborate on that, I'd appreciate it.
Sure, thank you. So in terms of screening and whether it's cost saving or cost increasing, part of it depends on the cost of the test itself. And if you have to screen 100 people to detect anything, that's going to tend to be cost increasing. The cost per test matters a lot. The other question is this going to lead to people being treated earlier in a lower cost way, or is it going to lead to a larger pool of people treated when the condition wouldn't necessarily have advanced? And they might, especially in the Medicare population, there are a lot of competing risks. Treating someone early may end up treating a condition that wouldn't have become clinically symptomatic, and that may just add to treatment costs. So the cost of the test, how sensitive it is, how specific it is, and the characteristics of the disease progression all matter. And I feel bad saying it depends, but depending on the test and the clinical condition, it really changes the calculation of whether it's cost increasing or reducing.
Okay, thank you. Again, my friend, Mr. Morgan, told us that, the one test, screening test, costs $1,000. That makes a lot of sense to me for early detection. So, and it saves money in the long run. Of course, increases a person's quality of care as well. Ms. Martin and Mr. Lyons, beyond premiums, both insurers and employers should have mutual financial incentives to keep employees healthy, and particularly on the front end through prevention and screenings. What ways are there collaboration between these two in a cost-effective manner? And then Dr. Ippolito, if we can follow up with this, how does price transparency help them meet this goal? So let's hear from Ms. Martin first, and then Mr. Lyons, then Dr. Ippolito.
Unfortunately, I'm not familiar with ways that employers and insurance companies are teaming up. That's beyond the scope of what we look at HCCI.
Okay, Mr. Lyons.
Yeah, thank you for that question. In New Jersey, what we did, we took an aggressive stance on primary care, and we've opened up several primary care centers so to make sure people have constant access. Because if you know right now, primary care is dwindling in the marketplace because of the reimbursements and doctors fleeing the profession. But what we did, we started a series of, first it was just for the general population of the state health benefits plan. And then what we did, and that price is very transparent, it's separately contracted. We started a first responders primary care health center, which I actually moved the resolution to get that done in New Jersey, and very proud of that. So we think that's the first way to get it moving. And then price transparency in general is going to allow people to make decisions. And I think transparency ultimately drives down price, right? Because, like I said, it'll shock the conscience. The best disinfectant is sunlight, right? So, thank you.
That makes sense. And I know that Dr. Bouchon will probably elaborate on that too, because he has several stories. Again, Dr. Ippolito, how does price transparency help them meet this goal?
Well, I think we can think of employers as being one of the few entities in healthcare markets that perhaps have a medium to long run view. They care about their employees over the long term. And so greater information, particularly along the lines of what's the more, the law we're talking about, or the bill we're talking about, will help them choose benefits that match their employees better. It helps them investigate where they're spending too much money relative to what they want. So it's a clear first step.
All right, very good. Thank you. I yield back, Mr. Chairman.
Gentleman yields back. The chair recognizes the gentlelady from Michigan, Ms. Dingell, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to all the witnesses in attendance today. Healthcare spending, both per person and as a share of GDP, remains higher in the United States than any other wealthy country. And despite this high spending, the United States has some of the worst healthcare outcomes in the world, which is appalling. It is critical we make substantive reforms to our healthcare system that not only reduce healthcare expenditures and lower costs for patients, but improve the quality of care patients receive. The House recently passed the Lower Costs, More Transparency Act, which contains many provisions led by members of this subcommittee that tackle some of the drivers of rising healthcare costs. This package takes steps to address predatory pharmacy benefit manager practices, something that drives me nuts, strengthen price transparency, lower out-of-pocket costs for seniors, and empower patients by ensuring they can access important information about the cost of their care. I was proud the Providers and Payers Compete Act legislation I led alongside Representative Burgess, Bilirakis, and Ferguson was included as part of this package. The legislation requires the Department of Health and Human Services to report the impact of Medicare regulations on provider and payer consolidation. Ms. Tripoli, can you quickly, because I want to go to another subject, elaborate on the recent trends we're seeing with consolidation in the healthcare system? What are the greatest impact on patients, and how is it affecting staffing?
Absolutely. I think the two biggest trends we're seeing are horizontal mergers between hospitals and other hospitals. We now have a situation where most markets across the healthcare system are considered highly concentrated. I think 90% of these metropolitan statistical areas are considered highly concentrated, heavily concentrated. And the other type of trend to point out is vertical integration, when these bigger systems are coming up and are buying up the small independent practices and forming bigger sort of healthcare corporations. The impact of consolidation in general is that from the data suggests that quality goes down in a lot of cases, and we know that prices are going up. Those prices come in the forms for consumers and higher insurance premiums. They're seeing abusive facility fees, higher cost sharing, and so it has a direct impact on the affordability of care. And we're seeing in a lot of cases quality going down, workers being laid off, wages reduced for nurses and other healthcare workers within the systems. So it's hugely problematic.
Thank you. I want to quickly turn my attention to home and community-based services, or HCBS. As many of you know, I believe moving care into the home is one way we can benefit patients while reducing costs. Medicaid is the largest single payer of long-term services and supports in the United States. And while state Medicaid programs must cover long-term care in nursing homes, nearly all HCBS are optional, despite several studies indicating HCBS can result in cost savings over institutional settings. And we know it's where people want to be. Likewise, according to a recent study of Medicare fee-for-service beneficiaries, home care was associated with a savings of nearly $6,500 per patient. And many of you have heard me speak about my experiences with home infusion. Several studies, in fact, have found that home infusion can lead to significant cost savings when compared to inpatient costs. Ms. Tripoli, do you believe transitioning care away from traditional healthcare settings like doctors' offices and hospitals can be an effective way to reduce costs and improve patient outcomes?
I think absolutely. I think, as you just pointed out, we know that shifting out of institutionalized care into the home or community-based setting with appropriate levels of care and support is not only important for consumers and patients maintaining their dignity, but also is essential, it's critical for having emotional and social connectedness, which has a direct impact on the quality of life. So that cannot be stated enough. And as we know, as you just beautifully laid out, the shifting into community-based settings does have a cost savings effect, and I think on average about 30-35% in reduced savings because of that shift.
Thank you. When it comes to reducing healthcare expenditures, I believe supporting the transition to home-based care is a critical part of the discussion. Thank you for that. And with that, Mr. Chairman, I yield back.
Thank you. The gentlelady yields back. The chair recognizes the gentleman from Indiana, Dr. Bashan.
Thank you, Mr. Chairman. I was president of a medical group. I was a heart surgeon before I was in Congress. Here's how billing works that's not transparent. I do bypass surgery on someone. We bill every patient $6,000, regardless of what their coverage is or whether they have coverage at all. Because you can't bill Medicare patients for what they might actually pay. For that surgery, it might be, and these are hypotheticals, might be $2,000. But for a private insurance company, they may pay $5,800. So what do? You bill everybody $6,000 to capture all the agreements anywhere from there. Usually it's between Medicare and the top thing. These are all confidential agreements that your practice has to sign with insurance plans, and patients, and honestly, most of the doctors don't even know what's contained in the agreements. So we have no way of knowing. That's just one lack of transparency. So the reality is, if you have no health insurance at all, you owe $6,000 unless the doctor decides to write that off, which 99% of the time I did. The other thing I want to say is, ironically, government subsidies, whether direct subsidies or tax advantages, are some of the leading drivers of healthcare costs, in my opinion. It seems like it should be beneficial to our society, and in many ways it is, but it also drives cost. It just does. We've also tried to control healthcare costs since the late 1980s by cutting provider reimbursement, and has that worked? Does anybody think that's worked? No. So now we've cut providers so much that we can't get doctors in rural America and underserved urban America. So we have to do more. We need competition and transparency. Basically, every one of you said that. I'll direct my question to Dr. White. As it relates to physician-owned hospitals, are you aware of a recent study on physician-owned hospitals from the University of Connecticut and Loyola University last fall?
I'm not aware of that study.
Well,
But
I have it here. I didn't figure you would, and that wasn't a trick question.
Okay.
I just wanted to make sure you didn't. It's called A Study of the Cost of Care Provided in Physician-Owned Hospitals Compared to Traditional Hospitals. It's an analysis of 20 high-cost diagnostic-related groups using 2019 Medicare claims data. And what it showed ultimately is that this study showed that physician-owned hospitals, that payments were 8 to 15% lower than traditional hospitals within the same market. So I'm asking for you to think about whether you can commit to having the CBO consider this and other new research on POHs in a reevaluation of prior policy.
we would be happy to consider that study, and honestly, we've been tracking this physician-owned hospital area for some time, and we would be happy to take on new information.
I appreciate that, because it's critical to competition in the marketplace. In many markets, as Dr. Burgess and others said. Mr. Chairman, I want to introduce that study for the record at the end.
Without any objection, we'll put it on the documents list to be reviewed at the end, so if somebody wants to review it, they have the opportunity to. Thank you.
Thank you. And Dr. White, also, one of the things that I've never been able to understand is how, and some people have already addressed this, preventive health measures don't reflect savings under CBO projections. I get it. If you do things preventative, people live longer, so it costs Medicare more money, so at the end of the day, it might not save as much as you might think. But what are we here for? We're here to make people healthy and to live longer, more productive lives. So, you know, I've just never understood that, and I think that the CBO needs to figure out a way to fix that, and I know it's a difficult challenge. So a question I do have, though, is on MA plans, do you think traditional Medicare or Medicare Advantage is cheaper for beneficiaries?
Cheaper for beneficiaries?
Yeah.
Let's see, it depends whether the beneficiary has Medigap plus fee-for-service or just fee-for-service.
Yeah, say for example, they don't have a supplement plan.
Right.
So let's, Medicare, traditional, MA plan, and Medicare.
Yeah, but my sense is that MA plans are taking part of the rebates, the payments that they're getting from the federal government and pushing down cost sharing. I don't have at my fingertips a solid comparison, but that's my sense.
Yeah, because recently there's been some allegations that MA plans are overpaid, and I understand that. But some experts now suggesting that there's a good reason to question MedPAC's conclusion on this. The CBO have plans to undertake a component-by-component comparison of the two programs. As you know, Medicare Advantage includes A and B benefits, prescription drug plan, Medigap coverage, and supplemental benefits compared to traditional fee-for-service. Because this is an issue, right? If you look at, and there was a Wall Street Journal article recently about profit margin for plans on Medicare Advantage versus, traditional Medicare.
Yeah.
So can CBO address that?
Yes, we actually have a team that's digging into the costs of Medicare.
And I'm over time, so you will address that?
Yes.
Yeah, thank you. I yield back.
Thank gentleman yields back. The chair recognizes the gentlelady from Illinois, Ms. Kelly, for 5 minutes for question.
Thank you, Chair Guthrie and Ranking Member Eshoo for holding this hearing, and thank you to the witnesses today. As health care costs continue to rise in the United States, the Biden administration and congressional Democrats have delivered for the American people by lowering the cost of health care and expanding coverage. More Americans have health coverage today than ever before thanks to the Affordable Care Act and the expansion subsidies included in the Inflation Reduction Act. Enrollment in coverage to the ACA is at an all-time high. 21.3 million consumers have coverage through the ACA marketplace in 2024. Ms. Tripoli, can you discuss the impact of the enhanced subsidies in the Inflation Reduction Act on coverage and how many new individuals have gained access to coverage?
Absolutely. Thank you for the question. I think as you just articulated, we've saw record enrollment in open enrollment this year, over 21 million people. That's 5 million more this year than last year's open enrollment. And I think the enhanced subsidies played a critical role to lower premiums for the American people so that when they went in and shopped in the marketplace, they could actually get a plan for $10 and could afford their health insurance. So the premium subsidies have been absolutely critical in terms of the affordability of people being able to afford their care and feel like they can actually purchase a plan.
Thank you so much. The enhanced subsidies in the IRA have led to historic coverage gains. Because of the enhanced subsidies, millions of families have affordable and quality health care. The expanded subsidies are also driving down costs. Can you also briefly discuss the impact of the enhanced subsidies on premiums and how it is lowering costs for American families?
Absolutely. The enhanced subsidies essentially helped shield consumers, absorb some of the growing costs of premiums, and shield consumers from that excess cost. So it brings their actual price that they'll pay for their premiums down. It does, of course, not address the underlying drivers of what's driving up healthcare premiums, which, as we know, hospital prices and drug prices are a major factor. But the enhanced subsidies are critical for making sure that the American people can actually afford their premiums and brings down the premiums for families.
Now, these enhanced subsidies are set to expire next year. Can you discuss the importance of making the ACA enhancements permanent?
It's absolutely critical. More than 21 million people afford in open enrollment getting healthcare coverage. We know that healthcare coverage is essential to keep people financially secure, to make sure that they get the preventive care that they need, that they're not delaying care and going to higher cost care centers down the road, making sure that workers can show up to work healthy, take care of their families. So a permanent extension of those subsidies is essential to make sure that we continue to have affordability for the American people.
So comments or claims that the ACA has raised healthcare costs. Can you comment about that? How you feel about that?
Some of my colleagues from CBO and economists might want to comment, but I think that we have seen underneath the hood of the healthcare system costs increasing. And I think what's important to note here is that subsidies are critical for the American people to access premiums. But what's underneath the hood of the healthcare system are pricing abuses driven by big healthcare corporations that are driving up premiums year after year because they're allowed to consolidate market power and increase prices year after year. So those prices have a direct relationship to rising premiums and have a direct impact on the affordability of care and the overall cost increases in the healthcare system.
So do either one of you want to make a comment? Who Ms. Tripoli referred to. Does anyone else want to make a comment about that? No? Okay. I yield back.
Gentlelady yields back. Now recognize Dr. Dunn, 5 minutes.
Thank you very much, Mr. Chairman. I appreciate this committee taking a holistic look at an issue that our constituents talk about to us at every single town hall meeting, and it's the high cost of health care. We hear from seniors on fixed income, chronic disease patients, parents who are just trying to give their children access to the best care, and of course, small businesses that are providing health care to their employees. The American healthcare system does not come close to a free market in which consumers can understand the cost of goods and services and make informed decisions and then spend their dollars where they see the best value for themselves. Perverse incentives, business practices that are shrouded in secrecy, leave consumers in the dark as healthcare spending rapidly increases as a proportion of U.S. GDP and faster than inflation. Now, when we're thinking about reducing healthcare spending but preserving high-quality care that Americans can access, there are many policies that make sense, but I think some of those are. We must take a thoughtful approach to site-neutral policies, ensure the proper oversight of the existing transparency rules, and take a very hard look at how vertical integration in both the provider side and the insurance spaces is driving costs. That said, I think the single area of greatest interest to virtually every one of my constituents is the cost of prescription drugs. I also think addressing drug spending is our biggest opportunity to generate real savings immediately, fast. The poster behind me illustrates the potential savings that clear and transparent cost information about generic drug prices could generate. You're looking at the cost of just 3 common generic drugs and their branded counterpart. As you can clearly see, generic drugs can be manufactured and sold to the consumers at considerably lower prices than when the patients go through their insurance plan. Another illustration of potential savings in hand is pointed out in a report of the Florida's Agency of Healthcare Administration commissioned in 2021. I'd like to enter that into the record, Mr. Chair.
Without objection.
Thank you. The report found that the spread pricing in Florida's Medicaid system, when a plan pays the PBM more per claim than what the PBM pays the pharmacy, benefited PBMs to the tune of $90 million a year. $70 million of that was generated by the spread pricing in generic drugs. Let's be clear, if the prices were transparent, this would never happen. If patients knew that their insurance company was often charging them 5 to 20 times the cash price of the drug, they would question the value of their insurance plan and the interest of their insurance plan. And they'd surely question why the heck the PBM was pocketing the differences. Some patients are tricked into paying thousands of dollars out of pocket for brand drugs by their insurance plan due to formulary design, when they could pay a small fraction of that price for a bioidentical generic simply by paying cash. A complicated web of markups, rebates, kickbacks, and ever-changing business models is actually designed to shroud drug prices in complexity and keep patients in the dark about the true cost of their medications. This must stop. A functioning market requires informed and empowered consumers, and I don't think anyone in this room would say that keeping patients in the dark about the true cost of their care is lowering costs. That may be a good model to generate profits, but I'm here serving my constituents, and I believe the healthcare system can work better for them. So how can we ensure more patients take advantage of these much lower prices you see here? And the answer is transparency. Dr. White. Earlier, I touched on the savings that Florida Medicaid program could achieve if spread pricing was addressed. You've scored this committee's PBM transparency bill as saving several $1 billion. I understand that additional reforms, such as delinking the PBM compensation from list price, would save additional billions. Can you confirm that? Can you turn your mic on?
Sorry about that. I'd have to look at the specifics, and I'm happy to follow up in written questions.
All right, I'll draw your attention to a bill called the Drug Act that's led by Dr. Miller Meeks. Mr. Ippolito, would you agree that marketplace competition often leads to lower prices and more choices for consumers?
In general, yes.
Good, that's a sort of market 101, right? I agree with you, but I fear that simply banning specific practices such as spread pricing might actually lead to hiding these abuses in another part of the system, which is why I encourage us all to continue to pursue complete transparency. You can't beat transparency in the end of it. The prices you saw, put that one more time. The prices you see here are prices that I can get at retail prices today online for pharmacies. Thank you, Mr. Chair. I yield back.
Gentleman yields back. Mr. Carter, you recognized 5 minutes.
Thank you, Mr. Chairman. Appreciate this hearing, and thank all of you for being here. You know, healthcare is a key driver of our debt in this country. All of you know that. $34 trillion in debt and healthcare. Right now, we're spending 17.3% of GDP on healthcare, nearly twice as much as any other developed country. And yet, despite spending almost $4 trillion a year on healthcare, patients and employers are unable to make informed decisions. Unable to make informed decisions about how and where to spend their money because our healthcare system lacks transparency. And I don't mean to sound like a broken wheel. I know that's what you've been hearing all day today from this committee, as it should be. Ms. Martin, I want to start with you. Can you tell me why the drug supply chain is such a black box for employers and for patients?
I'm not sure I know why it is the case, but it is certainly the case that there are elements throughout the healthcare system that are similarly black boxes, and it's why transparency is critically important.
What about the vertical transformation information that exists in the drug pricing chain, where the insurance company owns the pharmacy, owns the PBM, owns the group purchasing organization, owns the doctor, the physician's practice? You think that has something to do with it?
I don't think I can speak to that. I think there are, as I said, there are practices across the healthcare system where opacity reigns and transparency.
So essentially what you're saying is just transparency throughout healthcare would be the answer. Thank you for that. Let me ask you this. How would you describe how the Lower Cost, More Transparency Act can help employer plan sponsors better understand the cost of drugs especially?
I think the provisions of the Act and the increase in transparency will just empower employers with information across the board.
Thank you for that. Doctor, I'm sorry, whatever. Boy, y'all got some great names here on this panel. Thank y'all. And I apologize. PBMs claim that pass-through discounts from drugs manufacturers are passed from the plan to the patients. You know, as a pharmacist for over 40 years, I know that not to be the case. But your research found that in some cases, the average discount on drugs from drug makers is around 50%. In fact, there was a study done by the Berkeley Research Group some years ago, well, about a year and a half ago, that showed that only 63% of the price of, or excuse me, only 37% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 63% go? Well, it's going to the middleman. That's what we know. It's going to the BBM, which is the insurance company that owns the pharmacy, that owns the PBM, that owns the doctor. The largest employer of doctors in this country is United Optum Health Services, 9,000 doctors. So let me ask you, would policies like those that you see in the Lower Cost, More Transparency Act requiring PBMs and health insurers to disclose negotiated rebates help level the playing field, do you think?
Yeah, potentially. The numbers that you cite are not even unusual. 50%, 60%, 70% rebates, discounts are pretty normal, amazingly, in the current market. And so the provisions that are included in the bill, I think, at a minimum, make the purchaser, the employer, much more informed about how they're spending money and where they're spending money.
Mr. Tripoli, Mr. Chairman, next time, let's get a panel of Jones and Smith and, anyway, nevertheless, Mr. Tripoli, is it your belief that that correcting this misaligned incentive structure for PBMs and to delink the fees, as Dr. Neal was suggesting earlier, that that would alleviate some of the problems we've discussed that we're having?
I think transparency across the healthcare system is critical, including for PBMs, including for hospitals, including for plans. That information around prices, negotiated rebates, all of that is only going to help unveil the curtain around some of the abuses that are happening in the market, empower employers with more information they need to negotiate a better deal, empower consumers for the same reason.
Thank you for that, unveiling the curtain. You know, I've got a pamphlet out. It's calling Pulling Back the Curtain on PBMs, and I'd like to make a copy of that available. In fact, I'll get my staff to bring each one of you one of those pamphlets down here before you leave. But it does show the problems with PBMs and the need for transparency. Look, I'm not opposed to anybody making money, but come on, this is ridiculous. This is not being passed on to the patient. It is not going where it's supposed to go. That's why we need transparency, to show the employers at least where they are going, where these discounts are going. Thank you, Mr. Chairman, and I'll yield back.
Gentleman yields back. I now recognize Mr. Pence, 5 minutes.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this meeting, and thank you for the witnesses all being here today. As we've said, healthcare spending in the United States is continuing to skyrocket at an unsustainable pace. We spent an astonishing $4.5 trillion on healthcare in 2022 alone, an increase of 4.1% over the previous year. As the healthcare system continues to experience higher costs, particularly for physicians and providers that get rolled up into hospitals, as someone mentioned earlier, it's ultimately patients that suffered the most. According to the Kaiser Family Foundation, nearly half of American adults in the United States believe it is too difficult to afford health care, a real shame, particularly in rural America. Indiana had a $1 billion shortfall last year due to the difficulty of estimating the cost of Medicare, as Mr. Lyons discussed in what you do for your members. Rather than work to find common sense solutions to lower health care spending, the Biden administration is proposing a rule that would further exacerbate the issue by raising the delivery costs of health care. Under the direction of the White House, CMS proposed minimum staffing ratio requirements for nursing homes. This proposed rule, published in the Federal Register, estimates that the policy would cost $40 billion over 10 years to fully implement. I bring this up as we talk about transparency, we talk about how much health care costs. We're running out of providers in my rural Indiana 6th district. Dr. Ippolito, I have an Italian wife, so I think I probably got that right? Finalizing this HHS proposal would result in limited access to care for seniors, mandatory increases in state Medicaid budgets, and could most consequentially lead to widespread nursing home closures. A report commissioned by CMS analyzing a minimum nurse staffing requirement found that the quality and safety thresholds could and probably would increase a modest 1 percentage point. Implementing a staffing mandate for nursing homes would also put added financial pressure, as Congressman Carter, nothing wrong with making a little profits, but it would put pressure on healthcare settings to make money. And we have found, going around my district, I've found it would also drain staff from other areas. Dr. Ippolito, do you believe it's fiscally responsible for the federal government to spend billions of dollars on a policy that could result in a modest improvement in care when healthcare spending is already at historical levels? And what happens to the price of care as we decrease the supply of caregivers?
Well, assessing the full merits of the policy are probably beyond the scope of perhaps what I can speak to today. But what I'll say is two things. The first is that the context is right. Given where we are, if a new policy is going to lead to tens of billions of dollars of additional spending, it should be looked at with a critical eye. That doesn't mean you shouldn't do it, but it should be viewed critically. The second thing is the margin, I think, of relevance that you bring up is very important. Is this going to affect the financial viability of some of these institutions? And if the answer is yes, that's a meaningful trade-off. I can't right now weigh those things perfectly, but those are the two things I'd focus on.
Well, I wish this administration think about that, what they're going to do to rural health care as they run out physicians and nurses. So thank you, and Mr. Chair, I yield back.
Gentleman yields back. I now recognize Ms. Trahan, 5 minutes.
Thank you, Mr. Chairman. As I've previously raised in this committee, community hospitals across our country have faced significant financial challenges over the years, challenges that were deepened by the pandemic and in some cases are being made even worse by a private equity model that puts profits squarely above our patients and their care. In 2017, Steward Healthcare, the largest private for-profit health network in the country, purchased Texas Vista Medical Center in San Antonio with the help of private equity. This was a community hospital that served mostly working-class population. And while it looked like the acquisition might mean that the hospital would keep its doors open and all of its services available, the purchase allowed a separate company, Medical Properties Trust, to purchase the land and buildings on the hospital's campus so it could charge Steward $5 million in rent each year. Fast forward 6 years, and Steward announced it was closing Texas Vista because of low Medicaid reimbursement. But it mentioned nothing about the 30+ million it had to pay in rent to Medical Properties Trust, a company, by the way, whose CEO earned $70 million in salary, bonuses, and stock in the 4 years following the purchase of Texas Vista's properties. Mr. Chairman, this is what the disastrous reality of private equity in our healthcare system looks like. And the thing is, it's happening again. But this time, families in my district are the ones who are being told that they have to pay the price. Families who receive care at Holy Family Hospital and Neshoba Valley Medical Center, both owned by Steward, were recently notified that their care is now in jeopardy because of the corporation's gross financial negligence that's seeing the company try to shutter 4 of the 9 hospitals they own in Massachusetts. For their reasoning, Steward executives have pointed to, you guessed it, low Medicaid reimbursement rate as the cause for their financial distress. But earlier this month, it was revealed that the company has missed rent payments to an outside landlord that actually owns the property and buildings their facilities operate in. It's looking more and more like this is part of a dangerous Steward private equity playbook. Ms. Tripoli, hospitals have had a rough go of it post-COVID with workforce shortages, supply chain issues, and inflation. Do you have concerns about the increasing role of private equity ownership of community hospitals, particularly this type of purchase structure where a for-profit system purchases a community hospital with a separate firm purchasing land and buildings that it operates?
I think absolutely. I think we have to be very skeptical of the role of private equity in mergers and acquisitions in the healthcare system in general. Their business model is just incompatible with ensuring the health and financial security of the American people, particularly at the community level. And what we see when private equity comes in, they're trying to make they're cutting costs, they're trying to increase prices. We see quality go down, we see hospital-acquired infections go up, we see increasing in falls, we see prices go up, and they're trying to look profitable for resale in 3 to 5 years. And in some instances, as you've just pointed out, we actually see them closing the doors of those centers because the real estate underneath is much more profitable than the institution itself. So we have to be very, very critical and scrutinize. We need a lot more transparency around the role of private equity ownership in the healthcare system right now. That is a giant black box, and we need more data unveiled so that federal and state regulators can have greater scrutiny over the role of private equity in healthcare.
Thank you. I mean, when these hospitals are forced to close, like in San Antonio and now across Massachusetts, it's patients who suffer. Your testimony, Ms. Tripoli, urges our committee to continue to explore opportunities to improve transparency around the ownership interest of private equity and healthcare corporations. It seems doubtful that greater transparency rules alone could slow private equity's penetration of healthcare markets. Can you please elaborate on how we should be thinking about legislating beyond what was included in the House-passed Lower Cost, More Transparency Act so that our healthcare system is fully meeting the needs of Americans?
I think certainly in terms of the role of PE ownership, the piece about transparency is really, really important. It's a critical first step. It is because of how often private equity buys and sells within the time period. Oftentimes you see systems changing hands of ownership multiple times, and we don't have good insight into how often that is happening. And so that is why we actually need more transparency around the ownership, private equity ownership in healthcare, because that not only will allow us to have a better sense of what the trends are happening in the market around mergers and acquisitions related to private equity, we can identify other types of anti-competitive practices that are going on, and we can empower federal and state regulators with important information to scrutinize the role of private equity in healthcare mergers and acquisitions.
Very helpful. Thank you so much. I yield back the balance of my time.
Yeah, thank you for yielding, but we didn't start the clock on you. So you used your 5 minutes, but we gave you so we hadn't started your clock. So thank you for yielding back. And the chair now recognizes the lady from Tennessee, Dr. Harshberger?
Yes.
Yeah, from
Thank you.
Tennessee.
Thank you, Mr. Chair. Thank you to the witnesses for being here today. As you all know, this committee has driven meaningful bipartisan legislation that passed the House in December that would lower health care costs significantly, increase transparency of the historically opaque PBM sector, and also ban the use of spread pricing by PBMs operating in the Medicaid program. These reforms were influenced by the practices of so-called transparent PBMs like Navitas, Vintegra, and Affirmed RX, just to name a few, that pass all rebates through to their clients and do not spread price. Also, there's companies like Lumicera, a specialty pharmacy that sells its medications at the acquisition cost of the drugs, plus a clearly displayed dispensing and patient management fee. There's other models like that, and reforms to the traditional PBM and specialty drug models exist and can be replicated. The Lower Cost, More Transparency Act is a giant step forward, but there's still work we have to do. So we'll start with Ms. Martin, and this can go to anybody on the panel. I'm specifically interested in your views about other segments of the supply chain that would benefit from additional transparency, such as the role that pharmaceutical group purchasing organizations or rebate aggregators play in negotiating rebates for PBMs, because as you know, the FTC extended its study into PBMs last May to add 2 such pharmaceutical GPOs to its reviews. And my question is, are there other aspects of the pharmaceutical supply chain that you think need to be better examined? And if so, how might potential reforms in these areas help lower or moderate the growth of healthcare costs and spending?
I don't think there's any segment of the healthcare system that should be protected or shielded from transparency. I think we need transparency across the board and at all levels.
Well, that's true. Dr. Ippolito?
Rebate aggregators are pretty close to the top of the list for me, particularly because rebates have attracted so much attention. There's a lot of policies that are either being enacted or proposed that would amend how those dollars flow. Well, if rebate aggregators suck up those dollars before they formally become the rebates that have been regulated, it presents an obvious problem. Yeah. So that seems at the top of my list.
Doesn't it? Yes, sir.
Thanks for the question. One of the things that's really upset me, that really gets me going on this and digging into it, is the oncology drugs at the hospitals. Hospitals are marking up those oncology drugs 5 times.
Well, yeah, I used to work hospital as a pharmacist, so I
And then they're charging tens of thousands of dollars to administer them, right? Now, these are oncology patients. So that's one place that I would drill down on right away. And right now, the insurers have no interest because of medical loss ratio to lower that threshold. 20% of $100 is a lot less than 20% of $1,000, right?
Yeah, I got you. Yes, ma'am.
I think I just want to say, I think we have to just remember that drug companies are, in fact, really to blame for the drug cost crisis. But of course, as you mentioned, PBMs do have a role to play. There's an incredible amount of opaqueness around the pricing structures and business practices of PBMs. So I think increased transparency across the healthcare system, including PBMs, the drug supply chain, is only going to allow us to unveil again what's happening underneath the root, at the root, what's driving unaffordable care.
Yeah, yes, sir.
And as we scored in the Lower Cost, More Transparency Act, giving employers more information about where their benefit dollars are going, how much is going to the PBM, allowing them to shop among PBMs will lead to a more competitive market for PBM services. And with state Medicaid programs, similarly, we talk a lot about patients as consumers, but employers and state Medicaid agencies, they are buying and making decisions based on the information they have. And if state Medicaid agencies have more information about PBM costs and are better able to comparison shop among PBMs, that reduces PBM margins and makes for a more competitive market and
No
reduced
joke.
benefit costs.
They have to make their decisions based on the information they receive. And as somebody who owned pharmacies and had to make those decisions, we didn't get the whole picture. But you know there's discrepancies and transparencies are needed, for sure. Ms. Tripoli, the Paragon Health Institute recently issued a policy brief sounding the alarm on how mandatory spending on major federal programs for health care, Medicaid, Medicare, Obamacare, now exceeds our entire discretionary budget, driving up our $34 trillion in national debt and crowding out spending on other important national priorities. While we appreciate what the Families USA support the policies in the Lower Cost, More Transparency Act, there are some issues that we have to agree to disagree on. My question is, does Families USA's view that health insurance coverage from expanding Medicaid and ACA subsidies, should that be our main objective regardless of budgetary affordability, efficiency, or the quality of such coverage? And what is Family USA's position on a one-payer system or Medicare for all proposals here in Congress, recognizing that Medicare under the current law faces significant near-term and long-term financial solvency challenges?
So, Ms. Hart, can you just quick answer, like, quick? I'm sorry.
My time was up. I'm on a roll here.
I'm sorry, that's a big question, but can you have a quick answer?
Of course. The short answer is absolutely. Ensuring that the American people have affordable health care coverage is essential to making sure that people have health. We have to look underneath the hood of what's driving those expenditures and driving the increase in costs. And we know that there are major drivers, major corporatization of healthcare, from drug pricing abuses to hospital pricing abuses to abuses in Medicare Advantage and coding abuses that's driving up the underlying cost of care that are important areas for this committee to continue to talk about.
Okay, thank you.
Thank you for
Sorry,
that
Mr.
quick
Chairman.
answer. No problem. The chair now recognizes, the gentlelady yields back. Chair recognizes the gentleman from Pennsylvania, Dr. Joyce, for 5 minutes.
Thank you, Chairman Guthrie and Ranking Member Eshoo, for holding this hearing today and for our panel for your testimony. Healthcare costs are something that every American faces, and even planned costs can represent substantial hardships for the hardworking constituents that we represent. Costs continue to keep rising, and we must be looking closely at this issue and working together to find solutions, such as getting the Lower Costs, More Transparency bill signed into law. In 2024, total federal spending on Medicare, Medicaid, and inflated ACA subsidies will eclipse the size of the discretionary budget. This is not sustainable, nor is it resulting in better outcomes. In fact, life expectancy in the U.S. has fallen back to levels that we have not seen since the early 1990s. Overinvestment in some areas and underinvestment in others has led to issues such as reduced access. It has caused misaligned incentives across the entire healthcare delivery system, resulting in increased costs. It has lowered efficiency, and it has only accelerated declining outcomes. One such area of underinvestment is in the way Medicare compensates physicians. Even before rampant inflation and the COVID-19 pandemic, physicians were facing an unsustainable trend. When adjusted for inflation, Medicare physician payment already has effectively declined 26% from 2001 to 2023. And that is before additional inflation, and these cuts are factored in. Also, physicians saw a 2% payment reduction for 2023, and then again since January 1st of this year, a 3.7% cut. Ever-thinning margins increased pressure for independent physicians to consolidate with hospitals. Dr. Ippolito, could a policy that advances site-neutral payments and reinvests savings into physician fee schedules lead to less hospital-physician consolidation in healthcare?
Yes, and it would also attenuate the reductions in revenues to the hospitals themselves because, of course, that would increase the new payment rate, which is the fee schedule. So yes.
Dr. White, seeing how this continued underpayment has driven consolidation and required seniors to receive care in higher cost settings like hospitals, outpatient departments, how does the CPO account for these increased government outlays from consolidation when weighing the direct budgetary cost of providing necessary relief in the physician fee schedule?
Thank you for the question. So if policy were to shift from the current flat physician fees to being pegged to the Medicare Economic Index with automatic inflation adjustments, that would imply substantial federal cost increases for physician fees. If it were coupled with a substantial site-neutral policy, we would take into account whether that would dampen consolidation and maybe change the site of service, but we'd have to look at that carefully.
And I think these are issues that we need to continue to look at very carefully as we drive physicians away from accepting Medicare patients. On another topic, driving increased mortality rates, heart disease is one of the top causes of mortality and expensive hospitalizations among our Medicare beneficiaries. During the pandemic, flexibility for seniors to perform cardiac and pulmonary rehabilitation at home through telehealth waivers led to greater compliance with their care regimens and, in turn, fewer re-hospitalizations. Dr. Ippolito, there is data to show that cardiac rehabilitation can reduce hospitalizations by 30% among eligible beneficiaries. How can we best incentivize this high-value service and others like it that reduce patients accessing our healthcare system through the emergency room and other high-cost settings?
Well, the simple answer would be to make it financially worthwhile for people to provide, so through reimbursement probably.
And continuing access to those outpatient rehabilitations through telehealth is an important cost-cutting measure.
I'd have to think more about the specific policy, but it certainly could be.
Mr. Chairman, I'd like to take just a moment of personal privilege and thank a staff member of mine who is leaving and moving on to another facet of his career. Mr. Nick Nastasi, who's present here with us today, a native son of New Jersey, Wildwood, New Jersey, a graduate of Seton Hall. He's a proud pirate of Seton Hall. And I would ask each of us to join in thanking Nick Nastasi for his service to our team and to the Energy and Commerce Committee. Thank you, Nick.
Thank you.
Thank you,
for
Mr.
your
Chair, and
service.
I yield.
We wouldn't, this wouldn't work as well as it does without all the hard work that goes on from the folks who are behind us on both sides. So thank you. The gentleman yields back. The chair recognizes the gentlelady from California, Ms. Barragan, for 5 minutes for questions.
Thank you, Mr. Chair. The United States spends twice as much per person on health compared to other high-income countries, and costs are projected to grow. As we've heard today, this is not sustainable, and we need to do more to put patients first. And with that, I want to give a shout out to Power to the Patients, an advocacy group that's worked on healthcare price transparency. Thank you for the work that you do. I'm looking forward to working with organizations and my colleagues to build upon the committee's prior work to increase transparency and accountability, while also investing in evidence-based programs that will lower cost. Ms. Tripoli, your testimony about the challenges consumers have to understand the price of healthcare services from hospitals was impactful. I represent a district where almost 70% of households reported speaking a non-English language at home as their primary language. This often reduces one's ability to understand complex paperwork and the consumer protections that may be in place. How can we address unexpected hospital and medical bills in a way that is inclusive for people who are not fluent in English?
Thank you very much for the question. It's a very important one. I think in addition to making sure we actually get the pricing information and unveil it, we have to make sure that we have it translated into multiple different languages. And so I think that's probably the most important step. And that when, regardless of what language you speak, that when you go into the website, a hospital website, and you're actually trying to shop and figure out what the service is and how much it costs, that it's readable, that you can understand it, that it's explained, and there's an explanation, there's an actual price in dollars and cents, simplifying that information so that the American people can actually use the information as the end users of it is critical.
Great, thank you. We spend nearly $2 billion on dental-related emergency room visits per year. Almost 80% of these cases could be prevented with access to routine dental care. I led several bills that will expand access to routine dental care in Medicaid, Medicare, and the Children's Health Insurance Program. How can investments in dental care save money for patients and taxpayers in the long run? Yes.
I think we know that that right now we have a healthcare system that treats just the part of our body, but oral health care, dental care is part of our body. And when we have unmet oral health needs that go without treatment, without seeing a dentist or a dental provider, that impacts our overall health in the long run and can actually lead to higher cost care in the long run. So ensuring that we have a comprehensive dental benefit in Medicare and Medicaid and across the commercial market is critical to ensure that every person has the health that they deserve.
Great, thank you. Now, your testimony mentioned how surprise medical bills can lead to high out-of-pocket costs for patients, which in turn can contribute to medical debt. The Biden administration has released guidelines on rules against surprise medical bills. As a result, as many as 1 million surprise medical bills are being prevented every month. What additional actions can Congress and the administration take to build upon the success and continue to address surprise medical bills?
I think the first and foremost is to preserve the No Surprises Act and to keep it whole, to make sure that it's implemented in its entirety as it was intended in statute. We know that there are many threats to the No Surprises Act and implementation, and that directly threatens the ability of consumers to be protected from surprise medical bills. So I think first and foremost is protecting and continuing the implementation, robust, strong implementation of the No Surprises Act.
Great, thank you. Lastly, your testimony touched on how health outcomes are worse for people of color who experience higher rates of illness and death across a range of health conditions compared with their white counterparts. We know that Black Americans and Hispanic adults are also more likely to owe money for care. Can you talk about how the issue of medical debt can exacerbate health disparities that already exist in low-income communities and those of color?
Absolutely, I think medical debt by definition, is forcing people into a very difficult position where they can't actually afford their care and they're having to make trade-offs. I think this has a disproportionate impact on low and middle-income individuals, which disproportionately make up people of color. So we have to make sure that when we're addressing the affordability of healthcare, that when we're addressing the root causes, bringing down the price of healthcare at the root, it will help to eliminate people getting to the place where they have medical debt.
Thank you. I just want to thank again the committee for its work on lowering not just healthcare costs, but price transparency, which I think is a bipartisan issue that we've got to continue to move ahead and forward with. Thank you. I yield back.
Yeah, thank you for the comments. The gentlelady yields back, and the chair will recognize the gentlelady from Iowa, Dr. Miller Meeks, for 5 minutes.
Thank you, Mr. Chair, and thank the witnesses for testifying today. Mr. Lyons, employees place a great deal of value on their health care benefits, but we know that as health care costs continue to rise, employers have less money to spend on wages. There have been numerous studies linking high health care costs to lower wage growth, making it critical for American families that employers do everything that they can to keep health costs down while maintaining access to higher care. Can you discuss what strategies have been most successful in your plan, how price transparency can help lower costs, and if it would be of benefit to the United States to change their tax code that was incorporated after World War II to have healthcare costs as a benefit rather than wage increases?
Thank you. Being on both sides of the collective bargaining table, this is a very important topic. The plan that most municipal employees are in New Jersey is called the Rec 10. It's $45,000 for family coverage now. My members are paying $15,000 of that, but the taxpayers are paying $30,000 of that. We also have a 2% wage cap in New Jersey. So when we had a 31% increase over the past 2 years, there was no wage increase because that had to come out of their checks as premium. So where we have been successful, some time ago, we implemented a reverse drug auction. And the state, the estimate, and once again, I wish I could give you real numbers, but they won't give me the data. So, but the estimates were $2.53 billion over 5 years that we saved. So that's one place we've been fairly successful. We had some abusive practices going on in the state. We were able to cap them. I think actually I regret voting for it right now because it was the insurers' way of forcing people into their network, and we were used as pawns in that. So, but that did save a significant amount of money, and there were articles in ProPublica. There were some pretty intense abuses going on in PTOT and chiropractic, but we've got that under control too. But that's probably the biggest successes. quite frankly, we haven't had any successes in a few years. We're getting kicked around.
Thank you. Ms. Tripoli, Families USA has published a number of articles on rising healthcare costs and the role of consolidation and lack of federal action on policies such as site of service reform. A March 2020 MedPAC report highlighted a 30-year trend in increasing hospital consolidation, stating that in 2017, one single hospital system was responsible for 50% of discharges in most markets, and drew a link between hospital consolidation and higher prices for patients. In 2010, I warned about this very thing happening with the passage of the Affordable Care Act, actually before and after the passage, that it would lead to increased consolidation. Families USA has also published studies that claim hospital prices have increased roughly 31% since 2015, and that hospital consolidation costs the average American family $1,000 annually. What policy proposals, other than the lower cost, More Transparency Act, should Congress be considering to pump the brakes on consolidation, and do you expect consolidation trends to continue absent federal action?
Thank you for the question. I think absolutely we've seen a growing trend of consolidation dating back to the 1990s, I think, and even maybe before then. And so I think without federal action, without the oversight from the federal government and state regulators, I think we will in fact see the continued consolidation across the markets within the markets in the United States healthcare system. I think there are a number of solutions that Congress could be considering outside of price transparency and site neutral payment policy, but I think those two solutions in particular are so important for this moment. We have the Lower Cost, More Transparency Act, which of course has a limited site neutral provision for drug administration services. It's a foothold to a broader discussion that we need to have. And we hope that the members of this committee and your colleagues in the Senate and other members of the House will have about a more comprehensive site neutral policy. At the end of the day, we need to be thinking about policies that are going to address the underlying broken incentives in the healthcare system that incentivize big hospital corporations, big healthcare corporations from consolidating, buying up more market power.
Thank you. I have just a few minutes, so Dr. Ippolito, if you could briefly address this. You've written recently about shortcomings in the No Surprises Act and have stated that there would be an advantage to eliminating the IDR process and replacing it with an explicit payment standard or a requirement that facility-based clinicians contract with the same insurance plans as the facility. Who do you believe should be responsible for determining the explicit payment standard? And would there be a reason to believe that requiring facility-based clinicians to contract with the same insurance plans as the facility would cause more burden for the physician?
A very brief answer is that my concerns with the current system is that it's generating tremendous administrative costs both to physicians and to insurers alike. In terms of who would set up the payment, that would be Congress. I know that wouldn't be an easy question, but that would be where it would fall. And the rest of it, perhaps I can answer in a question for the record.
If you could answer in more detail in writing, that would be very beneficial. Thank you. With that, I yield back my time.
Thank you. The doctor yields back. The chair now recognizes the gentlelady from Washington, Dr. Schreier, for 5 minutes for questions.
Thank you, Chair Guthrie, and thank you to all of our witnesses today for joining us with all of your perspectives, which are very much aligned. 57 million seniors rely on Medicare for health coverage, and more than half of these beneficiaries are enrolled in Medicare Advantage, which has seen increased enrollment over the past decades. It's a lot like the health insurance that people are used to. In Washington state, 49% of Medicare beneficiaries are on a Medicare Advantage plan. Let me be clear, this can be a really good option for seniors. I know that firsthand. Both my parents have Medicare Advantage, and it provides good coverage, coupled with some benefits from my mom's union benefits. But Medicare Advantage is projected to cost CMS $943 billion by 2031. And if this is the growth that we can expect to be spending on these plans in the future, we're in trouble, and increased oversight is necessary. Now, I recently talked to a rural critical access hospital in my district, Kittitas Valley Hospital, about the administrative burden that accompanies Medicare Advantage plans. And they are hearing from their neighboring hospitals that up to 80% of Medicare Advantage claims are being rejected on the first pass. And this is after care has been provided. So rural hospitals are being forced to bear the administrative brunt of these denials, and patients are having to eat the cost, and it's just not fair, or sustainable. And I wish I could point to more official data on this issue, but unfortunately, Medicare Advantage insurers do not report complete data on denied claims for services that have already been delivered. This prevents us from knowing what types of services are being denied, if denial rates vary across enrollee demographics, and on what grounds these claims are being denied. But given the difference between denied claims from private insurance companies and from Medicare Advantage, this certainly raises eyebrows for me. Ms. Tripoli, how does this lack of claims data hinder necessary oversight over the Medicare Advantage program? And are there other areas in Medicare Advantage that you think need more transparency?
Thank you for the question. I think what you've laid out is, and you've described as a really, as one of several abuses that we're seeing in the Medicare Advantage program. This aggressive denial of prior authorizations, we don't have enough data about this, so it's absolutely critical to have pricing transparency around the prior authorization denials that we're seeing. We're also seeing this very aggressive marketing to consumers around what the supplemental benefits are at Medicare Advantage, and yet we have very little insight into what are the supplemental benefits, how are consumers using them, what is the value to consumers, and yet we have many complaints coming in, some record number of complaints that they're saying, what I was marketed is actually not what I'm getting the plan. And then, of course, we have this really systematic intensity of coding where MA plans are systematically making patients appear sicker than they actually are so that they can generate a higher reimbursement from Medicare. It resulted in $27 billion in overpayments in 2023 alone. That's significant. So we need transparency across the entire Medicare Advantage program.
So you mentioned $27 billion in overpayments, and that's compared to private insurance companies. What is that compared to?
I would have to look exactly what the comparison is, but when you're looking at the traditional Medicare program in comparison to Medicare Advantage, the research suggests that it's an overpayment, that they're upcoding and submitting coding intensity so that they can actually take down more dollars from the federal government.
So basically, fraudulent coding, total boondoggle for insurance companies, and you add that to vertical integration, and you've got just putting patients, hospitals, and the whole healthcare system at risk. I have a quick question to follow up with Dr. White. This is about how CBO scores. There's been a recent real demand for a class of drugs called GLP-1 agonists, like Ozempic, for example, that have been approved for adults with type 2 diabetes. They also have a pretty dramatic effect, weight loss, decreasing type 2 diabetes, heart disease, stroke, showing some evidence with addictions. It seems like if you look long-term, this could be real cost savings, but I'm wondering how CBO evaluates that and if you can take that into effect as we talk about perhaps negotiating a deal with those companies.
So this is going to sound a little like a broken record. We have a team working on the anti-obesity medications, GLP-1s, and what they're digging into is what's the price that Medicare would pay if those drugs were available outside of diabetes, and we're looking at what are the health impacts of people who go on the drugs, and in particular, what are the accumulated impacts if they stay on those drugs for years and years? There's a lot of.
I'm out of time. I'm going to thank you. Please submit in writing, and I yield back. Thank you.
Happy to.
Thank you, Dr. Schreier yields back. The chair recognizes the gentleman from Texas, Mr. Pfluger, for 5 minutes for questions.
Thank you, Chairman, for saving the best for last and letting me wave on to this committee. I appreciate it. And I think the witnesses, I represent a district, it's rural. We have about 3 or 4 towns that are about 100,000 people, so in West Texas. There's not a single event or a town hall or meeting with constituents that I don't go to where the cost of healthcare is not brought up. It's obviously a concern, so I appreciate you being here. I'll start with Dr. White. Just looking at the demographics, the expanding, especially elderly demographic that we have, in our country, and also an expanded demand for healthcare. What can you tell us about the observed escalation in healthcare expenditures, and to what extent is that demographic going to provide maybe a bubble of cost to our country?
Thank you for the question. So in the Medicare program, we're in the middle, maybe getting toward the flattening point of the baby boomers aging into Medicare. That's a huge driver of increase in Medicare spending. In terms of growth in per enrollee federal subsidy costs, Medicare is actually lower than for employer-sponsored insurance. With employer-sponsored insurance, growth in the prices paid to providers is driving up the per person subsidized costs. So in Medicare, demographics are a big deal. Eventually, the baby boomers will have aged into the program, and that will level out.
Thank you. Ms. Martin, for you, in recent years, the bipartisan commitment has been to achieve the substantial transparency in healthcare pricing for patients and payers. And can you kind of clarify how the enhanced price transparency can contribute to the reduction of cost?
Yes, I think opacity certainly hasn't served us well over the past few years. So just having understanding what is driving costs, how money is flowing through the system can help public and private decision makers understand cost drivers and to design interventions that can rein in healthcare spending.
Thank you. Dr. Ippolito, when employers choose a health insurance plan for their employees, they sometimes lack the insight into the payment negotiations between the hospitals, the providers, and the insurers. Does this limited information impede employers from selecting cost-effective and high-quality care options, and could making prices more available to the employer empower them to negotiate lower prices?
Yeah, the short answer is yes. If you give the informed consumer, in this case the employer, better information about what they're choosing, they have a better ability to cost shop against competing plans, I think they're going to make a better choice and save money.
I'll stick with you for just a second on hospital costs and how some, whether it's vertical integration or mergers and acquisitions or the purchasing of, using organizations to maybe purchase physicians groups and practices. Talk to us about how that's contributing to the escalation in prices.
Well, one part of that story is very easy. Horizontal consolidation, hospital buying a hospital, clearly increases prices, and it doesn't seem to have a major improvement on quality metrics. The vertical side, a hospital buys a doctor or an insurer buys a PBM, is a little bit more complicated, but there are certain risks, namely that you might steer patients to your own, other parts of your own entity that may or may not be in their best interest, for example. So those are the kind of things we know less about in the research world, but those are the kind of things that we would worry about in those settings.
Is there a rural aspect that is maybe over-exaggerated in that?
I think rural areas tend to have a more fundamental problem, which is even in the best case scenario, there might not be that many hospitals in the first place. There might not be that many doctors. And so, yes, these types of issues tend to be a little bit more exacerbated in those areas.
Okay. And I'll finish with Ms. Tripoli. In your testimony, you mentioned that there are few truly competitive healthcare markets left. And I think you said with 95% of metropolitan statistical areas having highly concentrated hospital markets, nearly 80% of MSAs having highly concentrated specialty physician markets, and 58% of MSAs having highly concentrated insurer markets. What measures are necessary to enhance the competitiveness? And then if you can also focus on the rural side, I've got 30 seconds left.
Sure. I think as we've been talking about, price transparency, unveiling prices, forcing the market to compete on fair prices, and quality of care is critical. Reducing some of the broken incentives that incentivize higher cost care and are incentives to consolidate. Addressing the markets and the condition around anti-competitive contracting practices, things that anti-steering measures are really important to increase competition in the market, among other solutions.
I thank the witnesses. Mr. Chairman, thank you for having me.
Thank you. The gentleman yields back. The chair recognizes the gentleman from Maryland, Mr. Sarbanes, for 5 minutes.
Thank you very much, Mr. Chairman. Today's hearing focuses on critical issues that an overwhelming number of Americans want Congress to take action on. In particular, this issue, obviously, of lowering the cost of health care. One area, and I know you all know this, where we've seen a significant increase in spending in recent years is Medicare Advantage. Enrollment in MA plans has more than doubled over the last decade, and per capita spending for these plans is both higher and faster growing than spending in traditional Medicare. According to MedPAC, in 2023, the federal government spent 6% more on MA enrollees than it would have spent for those same enrollees in traditional Medicare. but not because these beneficiaries had higher health care expenditures. In fact, they actually had below average health expenditures. Something wrong with that picture. High costs are instead driven by the fact that overpayments to MA plans last year expected to total $27 billion, and inflated payments as a result of insurers' intense coding practices will amount to an additional $23 billion on top of that. Ms. Tripoli, how do the over and inflated payments to MA plans increase costs for seniors?
I think the biggest abuse, as you outlined, is what we're seeing is sort of this systematic process where MA plans are actually intensively upcoding patients, making them appear sicker than they actually are. That increased the overall cost of care for the Medicare program, and eventually that gets absorbed back into the cost of care for beneficiaries.
And despite this high spending, taxpayers and the federal government have very little data on the supplemental benefits these plans provide, the supplemental benefits, which makes it very difficult to assess their true value. This is especially critical because in most states, individuals who opt to enroll in an MA plan when they turn 65 may be locked out from Medigap supplemental coverage with important consumer protections should they then choose to switch to traditional Medicare later on. Ms. Tripoli, would increased transparency from MA plans promote a better understanding of the value of these plans while helping to lower costs for seniors?
Absolutely, particularly as we're seeing such aggressive marketing from MA plans about their supplemental benefits. So yes, we need much more transparency around what the value is to consumers and what they're actually getting.
Mr. Ippolito, would you agree that more data on the value of MA plans would help policymakers make better decisions about how to lower spending while maintaining value?
In general, yep.
I've introduced legislation, H.R. 5380, to make data on the scope, utilization, and cost, including to beneficiaries, more available and consistent across health plans. Dr. Ippolito and Ms. Tripoli, I'd love to hear your thoughts. Would this type of data be helpful in controlling overpayments and ensuring tax dollars actually being used to promote better care and resulting in better health outcomes for seniors? Ms. Tripoli?
I think in general, yes. It would help. It would be helpful data.
Do you agree, Mr. Ippolito?
In general, yes, I do.
Yeah, thank you. I hope the full House will follow the committee's lead and pass H.R. 5380 to help continue increasing transparency and lower costs for seniors. I'm also glad that the committee has taken a significant step in this direction through the Lower Cost, More Transparency Act, which includes legislation that Representative Joyce and I introduced that would require hospital-based providers to use a unique identifier for each of their facilities when billing Medicare. And Dr. Ippolito, I'd be interested in hearing from you. Would simple policies like this that ensure providers are correctly billing under current law, or those that go a step further to ensure patients are not charged more for a service simply because of where it is provided, would that help contain rising healthcare costs?
Yes, I think it should.
Okay. I appreciate very much your testimony, and I yield back. Thank you, Mr. Chairman.
Gentleman yields back. The chair recognizes the gentleman from Texas, Mr. Crenshaw, for 5 minutes.
Thank you, Mr. Chairman. Thank you for all our witnesses for being here. And on this important topic, I think the way we pay for healthcare is the most frustrating thing about healthcare in America, and the way we finance it. And it's clear as day that it is the primary driver of our debt, despite all the hand-wringing and yelling and screaming about our annual appropriations process that we do up here. That appropriations process is completely dwarfed by our healthcare spending. New data shows that between Medicare, Medicaid, and Affordable Care Act spending, it actually is larger, just those three, larger than all of our discretionary spending. And I did not say Social Security. Social Security is not even included in that bucket. So that's really something. Medicare, Medicaid, ACA, all bigger than our entire appropriations bill that will eventually pass. Healthcare is a difficult issue because we want market forces to be available within it to create competition, which is what drives prices lower, and to increase quality. But we also want it to be available and accessible to all Americans. So it makes it a difficult problem. But I want to focus on how it is the biggest driver of our spending. 2/3 of our spending it's on autopilot, it's automatic. So, Dr. White, last year the Congressional Budget Office estimated the federal deficit would grow over the next 10 years by $4 trillion. But then 9 months later, that estimate changed to $20 trillion. That's a pretty big difference. Can you explain to me the role that mandatory government programs have in driving that deficit increase? $4 trillion to $20 trillion is a pretty big deal.
That's a complicated question. So I'll just say that there are a lot of moving parts in the update to our projections of the deficit. And I know my boss, Dr. Swagel, has been testifying to the House Budget Oversight Committee on updates to our deficit estimates for FY23 and going forward. In the healthcare space, we've actually been doing a pretty good job of projecting where those federal subsidies are going, and the federal subsidies for healthcare actually aren't a big player in the update of our deficit estimate for 2023. We did underestimate the take-up of the expanded enhanced subsidies for the ACA marketplace plans. We underestimated that. We've boosted our take-up projections of those plans, but it's not a huge driver of the updates to our deficit projections.
So can we, as these subsidies are set to expire, can we expect insurance subsidies to grow the deficit more if they're extended without reform, or you're saying they're not a big driver?
If the enhanced subsidies were extended past 2025, that would increase federal costs.
Do you have an estimate on how much?
I don't have one at my fingertips. I'd be happy to respond to writing.
Okay. Dr. Ippolito, during our last hearing, you had mentioned that direct primary care might be a more cost-efficient overall type of practice, since it's a form of capitation. What role do personalized care models like direct primary care play in creating a marketplace that lowers costs?
Yeah, so I stand by that assessment. In general, health insurance is good at protecting people against uncertain, high-cost events. Things that are routine, relatively low cost, are relatively bad candidates for inclusion in health insurance. So to the extent that there are innovative models that try and take it out of that relatively high administrative cost setting, I think that's worth exploring.
Well, I appreciate it. And Ms. Martin, you focus on patient behavior. What does a continuity of care approach, especially through options like direct primary care, do for addressing overall healthcare spending?
The impact of direct primary care spending on continuity of care is beyond the scope of what we would ordinarily look at, so I would like to think about that some more and get back to you.
Okay. One comment in my last few seconds is on the small business insurance costs. In 2021, small business employee premiums increased by at least 12% relative to the previous year. Based on the Agency for Healthcare Research and Quality data, we saw employee contributions rise by 24% in the last 10 years for small employers. And I think it's clear small businesses are bearing the brunt of insurance costs. And, Dr. Well, I'm out of time, so I won't ask the question, but I think it's important to level the playing field, allow small businesses to provide affordable coverage to their employees and congregate and associate as such. Thank you. I yield back.
Thank you. The gentleman yields back. The chair welcomes our member of the full committee to the subcommittee this morning, my good friend from Illinois, Congresswoman Jakowski. You're recognized for 5 minutes for questions.
Thank you, Mr. Chairman, and I want to thank you and the ranking member for allowing me to wave on to the committee, which is so important. Current estimates say that Medicare Advantage are over, what is it? Come here. Come, staff. What is it? Oh, I have been overcharging taxpayers by up to $140 billion. And this is a serious problem, I think, and to put this in perspective, $140 billion could actually pay for Medicare Part D, or it actually could be able to cover dental and health and vision care that would be done by traditional Medicare. Despite this unconscionable, I think, price gouging that we're seeing, I think in addition, we are now seeing that we are also seeing that private equity is getting into the picture here, and I wanted to talk to you about that also. So now we see that in Medicare Advantage, that there are now groups that are, I'm sorry, I'm having trouble.
Vertical integration in Medicare Advantage.
That what?
Vertical integration.
Yeah, we're seeing vertical integration of Medicare Advantage. And what I wanted to ask Ms. Tripoli, if you could talk about what this really means for this vertical integration is doing for Medicare Advantage. And it seems to me that it is contributing to the higher costs that consumers are having to pay.
Thank you so much for the question. So the evidence suggests that MA plans that are vertically integrated are actually more likely to engage in the upcoding, which is the practice that you're referring to that's generating these billions of dollars, multiple billions of dollars of overpayments. And this suggests that plans could actually be putting pressure on the providers that they have vertically integrated, so providers that they own, to increase the intensity of the coding, so to upcode their patients, make them appear more sick than they actually are, so that they can actually get a higher reimbursement, get higher payments from Medicare. So I would say this is, of course, a hugely problematic practice and one that should be scrutinized further.
Thank you. Well, you know, we're also seeing that the care is being sacrificed as well, that we're seeing a lot of people who aren't getting the services that they want. I hear it all the time in my office. Have you seen that?
Yes, well, we're seeing that many Medicare Advantage plans are aggressively marketing to seniors about the supplemental benefits that they could get if they enrolled in their plan. And what we've actually seen in the last couple of years is a huge spike in complaints from seniors saying that what was marketed to me is not actually what I have in this plan. So I think we don't have enough information, enough transparency around what the supplemental benefits are that MA plans are marketing to seniors and actually offering what the value is to consumers, how they're using them. And so I think increased transparency around, in general for Medicare Advantage, but particularly for supplemental benefits would be critical.
So I did want to say that private equity has become a major player when it comes to healthcare systems, and we know that 600% increase in private equity being involved in physician practices, and then we also see that 400 hospitals right now are now private equity. And so I also wanted to ask you, Ms. Tripoli, in your testimony that you talked about transparency is very, very important. I actually have a bill that would require these companies to divulge themselves. And I wanted to see if you could explain how private equity ownership may also interfere with health costs and maybe health outcomes.
Absolutely. I think we have to generally be very skeptical of private equity mergers and acquisitions in healthcare. The data that we do have suggests that quality does go down and prices go up, higher fall rates, more hospital-acquired conditions when private equity has come in and acquired a hospital system. In general, we have a lot of opaqueness around the change of ownership among private equity when they're doing mergers and acquisitions. So having more transparency around that level of information would be really important to better understand the trends in the market and actually would help to facilitate federal and state investigators to scrutinize private equity mergers and acquisitions in healthcare.
I appreciate that. I can see my time is up, and I yield back.
Thank you. Thank you for joining the committee this morning, and thank you for your questions. And thank everybody to be here to answer questions. I see no other member here present to ask questions. I know it's been a long morning, but it's been absolutely informative. And I don't think that you see as much on television that we are. There are some details that we have to work through, but we are really committed as a bipartisan to get this done so that people know what they're paying for health care. And I think I'd use about a minute. Do you want to say anything, or you can say that since I did? I just want to be fair.
I would agree. This is one of the biggest kitchen table expenses for families, and we want to know how to fix this in a way that serves patients and our entire healthcare system and does not become a boondoggle for people who are currently profiting disproportionately. Thank you.
Thank you. Thank you. And so now we'll move to, I'm going to ask unanimous consent to insert in the record the documents included on the staff hearing document list, which you have. Without objection, that will be in order. And then I'll remind members that they have 10 business days to submit questions for the record. And I ask the witnesses, I know you commented in your testimony, you're going to answer questions and you will have them in writing, that you will respond promptly to those questions. And members should submit their questions by the close of business on February the 14th. So that is the date you submit your questions. And again, thank you. It means a lot for you all to spend the time to be here. And we much appreciate it and have learned a lot. And without objection, the subcommittee is adjourned.